Sairam. Welcome to the day 2 of this All India meet of Sai Swasthya Wellness Centers and Sai Arogya Secondary Care Hospitals. I hope you got good rest after yesterday. We had a very interesting clinical session yesterday with lovely topics covering iron deficiency, anemia, pressure, first aid, health education, and some of the video we were just seeing. Today, it's a little different. We're taking a turn towards technology. These are all platforms that empower the work that we do, right? A clinician will do the screening. Yesterday, we spoke about the 3 key aspects of early detection, continuum of care, and timely referral. For these 3, it's very important that we empower this with technology. We back it up with technology, which can increase the efficiencies. And like some questions were raised yesterday about the time that it takes to do some of these just becomes faster. Imagine, and all of us have had some experience with, say, telemedicine, to be able to access, especially, say, wellness centers, all the Sai Swasthya are planned to be in really rural parts of the country. 1 in every taluk is the vision. There is no way you will have access to specialists in every taluk for all specializations. That is where telemedicine plays a very important role. So today, to sort of sum it up, we have 4 aspects for the session. The first is we'll have a talk on telemedicine and its importance, sharing some field experiences. The second, we'll have a demo of a platform for telemedicine. The third is we are going to have very interesting demonstrations on direct point-of-care devices that will enable easy diagnostics at the field level directly, which anybody can use. This is just for our experience, and then we can all evaluate which of them is relevant to what we are doing. And finally, we'll have a presentation and a discussion from the faculty of the medical college to share with us the timely referral aspect, because we are blessed that, like we discussed yesterday, the medical college exists, Sai Sanjeevani hospitals exist, Sai Arogya, the multi-specialty hospital exists. How can we, in all our wellness centers, if we find any patients who are required to be referred, what is the process within our ecosystem? We will commence today's session with a talk on telemedicine by Dr. Sriram. It is my privilege to introduce Dr. Sriram. He's a healthcare specialist with expertise in hospital and health systems management, an alumnus of the Indian Institute of Health Management Research. He brings deep insights into health technology, systems design, and care continuum. Dr. Sriram has played a pivotal role as a health IT advisor, leveraging telemedicine and information systems to enhance healthcare delivery, particularly in underserved areas. Today, Dr. Sriram will be sharing with us his experience and insights of telemedicine, which is an integral aspect of Sai Swasthya's vision of making specialized care available to the underprivileged. Dr. Sriram.
Presenter. Good morning. Sairam. Well, thanks for the good words, Soumya. I don't claim that I'm an expert, but I always felt that I'd been a good student, both in medical college as well as when I started my career. So, after 2 decades of practice in the remotest areas of erstwhile Andhra Pradesh, in the middle of a jungle, my journey with technology started sometime in 1995 when I bought my first computer. The place where I worked was absolutely remote. So it's a rainy season, the village is cut off. There are 15 hamlets around that village. The only issue is I was there because C.K. Birla He set up a factory there and a medical and a hospital. It's a clinic. When I walked in there were 10 patients per week. In 2005, when I relocated to be a part of the team of 108 ambulance services, the outpatient was more than 250. So meanwhile, once I was able to get I got my computer and then we were able to get the internet, I had the opportunity to get connected to most of my friends in Hyderabad, cardiologists, neurologists, various kinds of people. And in case there is somebody complains chest pain, take an ECG and then fax it or mail it and I get an advice straight away. So without wasting time, timely referral. I have not lost a single case. There were a frank case of 11 cases of MI. All these people underwent a PTCA. They traveled all this 180 kilometers from the village to Hyderabad and did it. So that's how it starts. So can I have the presentation, please? I will try to contextualize whatever I learned in working in various programs, especially as a part of Tata Trust, and before that, whatever I have done, starting with the career I had in the remote areas. Yeah. So I just wanted to name this one. I was wondering what I should call myself. There has to be a name. I was blessed with a granddaughter only around 6 weeks back, and then only yesterday they named her. So I thought I should be naming her. Her name is Ziva, meanwhile. So I thought that the appropriate thing is telemedicine. It is, can it be cateris paribus? Why cateris paribus? The meaning is, I am not trying to confuse you, other conditions remaining the same. I thought I was not trying to do any big deal. You people are already into primary health care and doing lots of things. And I had the opportunity to work very closely with Subhajit and understand the way he was able to connect his patients right from Sundarbans to specialty hospitals in Kolkata, and also make sure that they follow up, post-procedural, post-surgical and all that, both virtually as well as in person. And he was also showcased the fact that he was able to navigate. So not a big deal. So cateris paribus, I contribute to it, things remaining the same. Only thing is, we are trying to add an element of technology. Technology is always there to leverage, to make things better, not worse. To make it easy for the population, whichever is using, to make it easier for the providers. And then it can be, in a telemedicine context, once we are there, we have seen the whole world going to a paradigm shift, right from consultations to critical care. I will try to walk you through all those things and all. Now that's it. On the right side, you see a picture. This was shot in 2010 in Meghalaya. So I was part of the 108 ambulance service. I was the first physician to have joined. So when we went to Meghalaya, the first thing that we need to do is respond to an emergency and pick up the patient. Sometimes the paramedics had to go up 1 kilometer up the hill, bring the patient down to the ambulance because the ambulance can never reach. If that is so, in a case of emergency, what happens to the healthcare? And I try to compare. In the COVID times, as a part of Tata Trust, I was consulting patients in Mizoram, Meghalaya, Nagaland, even in capital like Delhi. Especially 80% of those consultations in COVID times were for geriatric patients, because elderly people, the way they died like rats in Europe, the same thing happened in this country. People were refused consultations, and even the textbooks and the triaging lessons also taught in crisis like that, when there are epidemics like that, when there is a surge in the critical conditions, you need to sacrifice. But where would they go? So we had an opportunity to consult all the geriatric patients across the whole country over a telephone. And then we use WhatsApp. This is telemedicine. So inaccessibility is a worst thing, and it continues to remain 7 decades plus of independence, and we are still at sea. After decades of extending healthcare, it was only in 2005 an ambulance services pre-hospital care was established in this country. So learning lessons from whatever we have done without trying to throw stones on that. As a good sense prevails where you start taking credit for the good things you do. So let us do that and try to take it up more. Now coming back to telemedicine part of it, right from ambulatory care to acute care, and you can have the mobile health, and you have the critical care monitoring. Can you do that? Yes, it can do that. It's no big deal at all. So population health, that's what exactly you are going to do. Whatever you have been doing that. And now we are stepping up and trying to enhance the service, enhance the quality of the service, trying to connect the patients as the three catchwords like early detection, care continuum, and then referral at the right time, making sure that things happen. So there is it's not a big deal at all. I thought telemedicine is only a piece of cake. That's what we had been doing. Right from after finishing the medical schools, the friends and relatives, and then in case somebody else says that, oh, okay, my son is a doctor and all that, in case you have a problem, talk to him. Like a billion of other doctors across the whole globe, every doctor was consulting on a telephone. That is telemedicine. No big deal at all. You want to give a fancy name? That's a fancy name. Where all we can leverage it. Can you use this kind of remotely? Can you train people? Yes, it can be done. If it is going to be a part of medical education, it is telemedicine. It is up to us how we would want to explain it to yourself, tell yourself and tell the whole world. But only thing is trying to make things happen. And in every part of, in every way, whether learning or care, patient management, there is only one way of doing things right. And we'll try to see how things can be right. And I said it's not a big deal, but you can see a picture. It is there in Wikipedia. You can just browse and then next time in the evening and say. Telemedicine has predicted 1925. Where are we now? 2025? So how old is that? I think older than me. Now, this is the present condition and more than whatever you can see. You have telehealth, you have teleneurology, rehabilitation, mental health, radiology, dermatology, pathology, teleophthalmology, telesurgery, and telepharmacy. And there are more and more, and it will occupy more slides. So the idea is to be able to push the boundaries of virtuality. And then it takes actually more commitment, more intelligence, and then a quick decision making when you are in telemedicine, especially consulting as a doctor, because you need to be smart enough to be able to understand the patient and be smart enough to not to ignore the right things. And at the other end, you have your surrogates who are your eyes and your hands. And can you make them examine the patient for you? And most often when I say examination, it's the benefit of the doctors here. Just like you work in the emergency room, it is a scenario in every teleclinic. Please do note this. You are not assessing the patient. What exactly you are doing is trying to process an undifferentiated patient. Somebody at my age, I'm just 73 years young, the way in case I throw a heart attack, the symptoms are different. I may not be experiencing chest pain. Do you agree with me, the physicians? I may, for all reasons, especially because of my being, with my family history, my mother died of a triple cell block. So by default, I had been on aspirin for quite some time. If I get some acidity and all that, I don't know whether aspirin has caused it or I'm throwing an inferior wall infarction. Is it possible? Can you differentiate? It's a challenge. Do you need to keep all these things in your mind? That's right. It has to be innovative and more intelligent, alert, and be sensitive to the patient's condition. Anybody walks in. So be careful. That's the reason. It is better to be on with a principle of abundant precautions. Try to be very clear and prepare yourself before you step into it. And the challenge is, whatever you are doing, this is going to be more, adding more. So other things remaining the same. Whatever you have been doing, work we're doing, Telemedicine, once you want to leverage technology and exploit it to the maximum extent, that's where you end up. So get ready, get set and go. Well, we spoke about whatever you have seen is the hospital environment and specialties and all that. This is what we thought, basis our experiences. I was a part of Tata Trust and we loved it. I was sharing with Swamiji that we had the opportunity to work very closely with Ramakrishna Mission. And we leveraged telemedicine in that program in Varanasi, Mathura and Vrindavan. Varanasi, we were able to close the project earlier. And Vrindavan, it lasted more time. And it was a fantastic experience and journey. We tried everything, whatever we wanted to try. We did not stick to one model. We thought that we kept options open. Whatever we can, we should try. Try it out. If it fails, fine. Not every time that you go to doctor with headache and fever, either because he's not coming down or doctor wants to make more money. So you have to try different things. So the way that sometimes you are lucky, you come out, and sometimes it takes time. So we used phone calls earlier, telemedicine. Text us once, try to text it and all that, your relatives and friends send you. I have headache and body pains and all that, I'm traveling, can you suggest some medicine? And then came the technology, videos. People wanted to talk on video or WhatsApp. Before WhatsApp came, then we used Skype. And I was consulting my sister in Canada. Because he went for a small ailment, they don't have the luxury like the way we enjoy life here in India. You need to have an appointment. Even for a small thing, you need to go to emergency room, and it takes. In fact, when I fell sick in Canada, in Montreal, it took me 4 hours waiting for a doctor to come and see me. And finally, she comes and walks in and says, take the paracetamol, and then wait for 3 days and come back to me. Then I told her, Madam, I am made in India. I'm working in Africa, now I'm in Canada. Unless you give me a shot of chloroquine and a heavy antibiotic, this fever never come down. Then he said, why the hell you didn't tell me that you are a medical doctor? Right? So, as we go coming back, consultations to critical care. Now telemedicine is being leveraged in home care. Home care has made things very easy for people, especially elderly. And more than that, home care has become a big business prospect for most of the corporates. Geriatric care, you can leverage it. Palliative care, absolutely. And then to the best, it was utilized in COVID times. Not because that we are looking at the patients, but more for the clinical safety of the healthcare providers. I can't give you the number of doctors who lost their lives. I can't give you the number of doctors who had to face insults. I can't give you the number of nurses and other paramedical persons, the way they had to go into the field, and they had been thrown out of the societies. In the middle of the night, this was in Assam, a family was asked to get out of the place because they rented, and both the wife and husband tested positive, and there was a baby. All these things happened. And mind you, both the wife and husband were medical personnel. The wife was a medical doctor, and then the husband is a paramedical guy, is a pharmacist, has a master's in pharmacy, and both of them were working in hospital. They were asked to get out of the place. 2 o'clock in the morning, I got a call. So luckily, we had people working in Tata companies. They were able to transport these people, and then actually, in fact, those days we hired some hotels. Taj helped us. We were housing all these people for in case of any crisis, and that helped us. And now we have in a big way things happening in public health. Ayushman Bharat and NDHM, they keep promoting telemedicine. So learning, now American Heart Association, International Trauma Life Support, agencies where they never stopped. And then critical care skills have to be taught. So basic life support courses. I'm an instructor of American Heart Association. I teach BLS, I teach ACLS, I teach PALS across the country. So they define the program, hardcore BLS. You learn. And when it is feasible, when it is possible, you go to the lab and then test your skills and then practice and get your card. Advanced cardiac life support, emergency care for nurses and physicians, critical care, it was available free of cost, which was offered by Society of Critical Care Medicine, both for pediatric patients as well as adults. And trauma care, international trauma life support. There are lots of trauma cases. I was participating in lots of webinars and all that where doctors, they were worried about trauma. And many things happened, And especially nowadays of the so-called interoperability of information, because this is the most important, I kept it to the last. Because yesterday Sadhguru, he shared his vision of n number of primary care hospitals, primary care, secondary care, and connected with tertiary care and quaternary care. So if you are able to consult in Kashmir, if you come down to Kanyakumari, you should be able to get your medical record. The way your information is captured with a standardized, what you call nomenclature, typhoid has to be read as typhoid, whether in Kashmir or Kanyakumari. So without any ambiguity, you should be able to reproduce the same way, the way you thought it, everybody should understand your thought. So that is the reason for codification. So ICD codification, you can learn it. It is available free of cost. I spent 3 months and I stopped working for 3 months and learned ICD-10. And then you have SNOMED CT, which is currently accepted in the government of India as a partner. And then for laboratory and all that, you have Law Inc. All these courses are available free of cost. Codification is one thing which I would recommend that slowly, some of you who are interested, please start browsing and then start learning. And before IT team makes it mandatory for all of you to get into that. So there are various ways and we give fancy names. And unless we give fancy names, we won't enjoy it. That's the reason. We call it actually basic modalities are so-called asynchronous and synchronous healthcare systems. Asynchronous is like, you send me your health reports and tell me your problem. Sriram, I have a headache, a cough, cold and all that. And I have a meeting tomorrow, I need to speak, my throat is not bad, can you help me out? So I read it after 5 minutes and then I send a prescription. That is asynchronous, no big deal. It is up to you how you want to put it and a number of ways. Synchronous. In case we are quite friendly and all that, you give me a video call. I said, I have something here and it is itching. You show me that or video. I see it. I ask questions. In case you have any reports, you read out, I understand. I give a prescription. That is synchronous. It can be one-to-one. It can be one-to-many. It can be many-to-many. Many-to-many in the sense that we tried it out with success, especially for in villages, where elderly people like me, usually we spend time under a tree, talking to each other and complaining about the daughter-in-law and the son and all, everybody on the face of this earth. And of course, politics is the usual kind of topic for discussion. And when they want to go and then suddenly somebody says, I want to check my blood pressure. Everybody, they come in a group, and most of them are hypertension and diabetics. When we started introduce diet consultations as a part of wellness, when you talk of wellness, most often, even in the hospitals, more so in telemedicine, the way it is being practiced now, you only think of medical doctors. And you are talking about wellness, why the hell you are forgetting about nutrition? Why the hell you are forgetting about rehabilitation? And unless you do it, and then even psychological counseling. See, when these people used to come, the consultation for diet, they were getting into waiting list. Then I had to tell them that you do one thing, you try it out. You address them as a group. Around 10 of them, they're around and all that, and you have a screen there, 55 inches monitor. Talk to them and talk to them about the diet, about diabetes, about hypertension. They enjoyed it. They were talking to you. We encourage people to talk. They were asking lots of questions. They were sharing. Some of them are better than the nutritionist because they know the local foods. Some of the recipes which my mother, I learned from mother, they don't exist in the market. I can share some of them if you're interested. The best thing that can happen is collaborative decision making. Multiple multidisciplinary teams, meetings, emergency response and real-time clinical decision support system. Sometimes the way you practice emergency in medical care, critical care, actually, we simulate aviation. Especially if you are a fighter jet pilot, you need to protect yourself and you need to kill the enemy. You don't do either, you are not doing your job. If you get killed, that's the end of it. The aircraft is gone and you are gone. So instantaneous decisions. And after comprehending the whole thing, understand the whole situation. Situational awareness, complete understanding, that's the backbone. And it is up to you to take it to higher heights. This is the areas: intensive care, mental health, diagnostics, and training is one of the main components, 5 components. A graphic on that. Scope of services, that's the reason I was walking you up to this one. This is the laundry list of all the services that can be handled. We try to do as many as possible in some of the programs last 6-7 years. Even admin people, in one of the webinars in COVID times, one medical superintendent, basically an orthopedician from, I think it's Cincinnati, he said, the first time I understand, because they were doing e-visits, e-rounds, because many doctors were not able to join, so a restricted number of doctors were being posted, asked to work, and the hospital has to be manned, and hospitals, once they are open, they cannot be closed. They are open for life, as long as the hospital is kept alive. If that is so, the services are to be available 24/365. So because of the restrictions and all that, so there were e-visits, e-rounds, and administration and then medical practitioner sharing information, taking support. He said, for the first time, I realized that administration and the doctors, medical fraternity, they can work closely. Usually they don't. I don't know how it happens here. In corporates, that's the problem. So models of the intervention, these are all, again, I think you have seen the laundry list. This is a abridged one. The last one is very important, because telemedicine gives an opportunity with due respect to medical professions across the globe, more so in India. Doctors, medical doctors, by default in this country, where our documentation is poor, not acceptable. Because the way you write a prescription, there is an age-old joke. Once you look at your prescription, then they question you, are you a medical doctor? That's the first question they asked me in the US when I wrote my name and my child's name and sent it inside to pediatrician. He said, looks like the parent is a medical doctor, call him inside. Right? So unless you understand, it becomes very important telemedicine, because the reason being, even for real-time consultation, more so in telemedicine, patient coming to you for the first time, you talk to the patient, you examine the patient, you advise some tests, and you give some initial prescription, and the patient in the next visit comes with the reports, then you come out with a provisional diagnosis. And unless the patient develops a different kind of symptoms, unless the reports, they speak more stories, suddenly you realize the patient is a diabetic, which he never knew and the doctor never knew. And you give a prescription and you ask the patient to come again and update as how he is doing it. Take this medicine 5 days and come back to me. We'll see how after 5 days. So patient is coming for the 5 days, after 5 days. So there are 3 visits, visit 1, 2, 3. In telemedicine, by default, the data is recorded as visit 1, visit 2. In the visit 3, I get to know. I can look back and see what I have done in my great job I have done in visit 1, how I examined the patient, how the things happen in visit 2 and visit 3. And if it is a chronic care management of diabetes, at the end of the day, after 12 months, the patient is coming back to you, you will get to see how the HbA1c was, what is the trend. Is the sugars behaving normally? HbA1c behaving normally? Are there any new symptoms in visit 6, visit 7? Or that can be learning to the doctor. It's possible that I missed out. I only have myself to blame, not to blame the patient. So that is going to help you to do kind of some research for your own self-benefit, your own benefit and benefit of the medical fraternity. And capacity building, we already spoke about it. So coming back to the kind of learnings, we had the opportunity to test it in Uttar Pradesh, as I said, in Mathura, Vrindavan and Varanasi, where Dr. Amol is here. He will be demonstrating the medical devices which can be connected. So there they used 2 mobile medical units and made sure that they encourage population to come for screening. And then they connected them, diverted them to a teleclinic which is close by, not within 2 kilometers of area. And we made sure the teleclinic is beyond 5 kilometers of any government facility, sub-center. So that we don't try to compete with the government. The idea is not to compete. The idea is to extend as much help and as much care to the public. So people started, initially the crowd was small, the footfalls were minimal, the numbers started picking up. And we have the doctors in Ramakrishna Mission in Vrindavan, and then the paramedic, the telemedicine coordinator. These are, luckily in Rajasthan and in Vrindavan, they had male nurses from Rajasthan. I will talk about it, I think by time. Be careful, other day I was talking to certain people. He had the luxury of employing male nurses in Vrindavan. We didn't have male nurses in Vijayawada here in Andhra Pradesh. We had to employ girls. And in case your Swastha clinics are in the remote areas, in villages, be careful when your girls are working inside. Their security and their safety is most paramount important. We have seen teenagers parking their vehicles in front of the clinic and trying to harass these girls. And then, very interestingly, elderly people like me, 4 or 5 of them, they find it convenient to enter the waiting area and sit there and keep chatting. Can you ask them to get out? I don't know. So these are the things that which will happen. I think most of the guys who are into operations, be careful. I will touch upon some of the feasibility points. So that's what we have done in Uttar Pradesh and Andhra Pradesh. Andhra Pradesh, we had teleclinics, 20 of them, and a hub with 6 doctors. There is an application connecting these 2 people. And I trained the nurses for about 6 weeks and made sure that they understood how to examine a patient, how to connect the patient, how to talk to the doctor, how not to intimidate the patient, how to educate the patient. Because some of the patients who come, they may be my age and already have a technology in my ears, so they may not have a technology. So if they can't hear properly, but the thing is, most of the patients, I think doctors will agree with me, especially with the specialist consultations, they're scared to ask questions. They look at you and then try to tell you they understood everything. What do they do, especially after specialty consultation? Most of my relatives and friends, they come out and give me a call. I met the cardiologist and he said something, can you explain to me? I said, you paid $1,500 and waited for 4 bloody hours and you asking me? No, he was very busy. So, this happens, right? So the person, it will be a nurse or a non-medical person who is next to the patient, should be paying attention and counsel the patient, explain to the patient. Take time. It's a life you are dealing with. You don't know. Somebody can be walking out of the clinic and then arrested. I can tell you stories in Apollo Hospital where I was in the emergency room. We had to shock 3 patients right at the doors of the emergency room. And we couldn't believe it. Then one patient arrested just before we brought him out of the ambulance. Then we had to come out with a protocol. The moment anybody, the Apollo ambulances go and pick up a patient, he gives a call to the emergency room, the security is alerted, and the ER is alerted. The protocol is a doctor go with a stretcher and housekeeping staff and nurse with a defibrillator monitor and oxygen below the gurney. You exchange oxygen from the ambulance to the patient and connect the patient to defibrillator monitor and you walk in. In spite of all this, in de-escalation from cardiac intensive care unit to medical intensive care unit, the patient arrested in the corridor of the hospital. That was a major incident. Things can go wrong. Don't think just because we are going to want to make it very simple, that you are going to treat cough, cold, and some acidity in teleclinics. The person who has come, for all reasons, may be throwing a heart attack. Do you want to enjoy it? Please don't. Be ready for that. There is help available. You should be aware. It all goes into training. In medicine, every one of us, nurses and doctors, were trained. When we consult, we pay attention to any life-threatening conditions. We pay attention to sinister conditions like cancer. We pay attention to metabolic conditions like diabetes. Then we also consider the complaint with which the patient has come. By default, it doesn't take much time. When you are working in a public hospital, you don't have time. The maximum time that you can enjoy is around 2.5 minutes per patient. There are 1,500 patients waiting outside. There are 10 doctors here. And then the bottom line is no service denial. You need to have that's the reason if you want to look at that one, look at that way and trying to match the number of doctors who are going to consult. Just because you want to make a modest beginning doesn't mean we want to start with one doctor. Let people learn. Doctors need to learn how to consult in telemedicine. The cyber etiquette has to be there. You need to get connected to the patient, then talk. The advantage is you have the health record well before you start talking to the patient. You get to know, address by their first name. Be respectful. And they will enjoy it. And don't try to ask questions straight away. Have a smile on the face and let them enjoy it. He's sick. That is what compassionate care, right? That's what Sadhguruji was talking about yesterday. If we don't do it, definitely we are not doing that kind of thing in here, in this model. So the volumes speak. 2 lakh consultations in Uttar Pradesh, 1.23 lakh consultation in Vijayawada, and then best thing is 3 crores of out-of-pocket expenses, savings on medicines. We sold medicines, but on cost to cost. Usually, I think people who are in the administration, they know. The way we purchase medicines in the hospital, we get for 20% of the MRP. And we offered for the same price to the patient. And point of care diagnostics we used, and we get a comprehensive data. We try to experiment on urban primary health centers in Maharashtra. Then the best part, which is very relevant to the present context, is when you are talking about timely referral, detection, continuum of care, and timely referral. Continuum of care, we had the opportunity to showcase in Telangana. Good number of Basti Dawakhanas, good number of primary health centers, good number of health and wellness centers, sub-center level. The opportunity to get connected. We scheduled appointment with the specialists in various teaching hospitals and district hospitals, including psychologists. We scheduled appointments and we reminded the patient and doctors they were able to interact. And I can tell you, the number of consultations were beyond our imagining. 2.2 lakhs of consultations over a period of 3 years. And we were able to condense the cycle time. The best case I can tell you is, a child was coming with recurrent attacks of fever. Every now and then child is sick, brought to the primary health center. So we have our own doctors, including myself, were sitting there, and then I just bumped into this case and I told him, he said, this kid looks like that is coming in for the 7th time. Why? I said, do we have a blood picture? No. So immediately I said that in case we have a coordinator there, in case they don't have money, you get the blood picture. Go outside, take the patient outside, get the blood picture, and let me know. The case was, the child has leukemia. Immediately we brought the patient to the MNJ Cancer Hospital in Hyderabad. We fixed an appointment, made sure the patient traveled. Within 1 week, the child was admitted in MNJ Cancer Hospital in Hyderabad. You condense the cycle time that it reaches. It may be too late. And especially in an emergency or dealing in systems of care in stroke and then acute coronary syndrome. Time is heart, time is brain. These are end organs. Once a tissue is lost. And best thing is to lose life than going to stroke. In EICU program, very interestingly, we have Nizam Institute of Medical Sciences in Hyderabad. And then one of the health commissioners in Telangana, she was a passionate lady, medical doctor herself from Kashmir. And she had the idea, well before, thankful to her, well before COVID, she set up 10 intensive care units in district hospitals. When we went up with the proposal, she said, sir, I love it. I'll bring these things to the table, you do whatever you want. So we were able to get an application, connect these intensive care hospitals, units in districts to intensive care, critical care medicine in Nizam Institute. And mind you, only those patients who required to be transferred, required to be referred to Nizams, only those patients reached. The rest of the patients were taken care then and there. When it was beyond the window period, thrombolysis was done. Patients are saved. Initially it started off 6 emergency conditions, and later it went up. Then we realized that emergencies are everywhere, especially pediatrics. Very interestingly, the people in Nurofer Hospital, the pediatric hospital, they were interested. Now in Nurofer Hospital, we have a hub EICU. They are connecting to 20 PICUs, pediatric intensive care units. This model happened after they enjoyed the luxury of EICU program in Hyderabad. As a part of it, for the first time I understood that there is no ECMO available in public health system in either Andhra Pradesh or Telangana. As a part of COVID support, we gave away 5 ECMOs. The big question came from the director, what do I do after 5 ECMOs after COVID? I said, use it. ECMO doesn't have any role in COVID. Pardon my temerity to have said it. It was misused rather than used. But now they are using in their transplantations and various other higher procedures. 3 of these things are put up in the theaters, 2 of them in the intensive care units. So it is up to you to be able to repurpose, up to you able to use them differently, the technology. Beyond Tata Trust, I had the opportunity to work in one model which is very close to whatever we are envisaging here, Kriya Healthcare. Here, in the remotest villages, we had clinics, and then we did not get the nurses, we got the GNMs, ANMs, not GNMs. And we trained these girls, they got connected. We have a hub of doctors, 6 specialists, retired professors, voluntarily, because all of them, they were close friends, they studied medicine together, they did their post-graduation together in different disciplines. They gathered, they used to have a cup of coffee and play cards and consult. That model, I really enjoyed working in that model. It was absolutely, and then the only difference being, I had 2 physiotherapists and 2 nutritionists, and made sure nobody is, because they can skip after talking to doctor. We made sure they have to speak to the nutritionist and update about their compliance to diet and also about the activity. So one of the things which I did for a business house, it was a vast thing where we worked for 2 years and developed a decision support system. And this particular business house is into whatever I said earlier. They are trying to push the boundaries of virtuality in every aspect of extension of help. Call it home care, call it diagnostics, call it drugs, call it medical tourism, everything. So the thing is, idea is not to talk about business. Idea is that you can do anything, whatever you want, you envisage, you will be able to do it. So in one program in Panchkula, in Haryana, that they also combined personal security. So everything virtual. And of course, there were security vehicles and of course the ambulances and all that. And I made a home visits and then saw elderly people and update their records. Because I get to know the basic, because it was a membership kind of a program, a model, where things were much easier to handle. So requirements, I think that is all the stories, but the real things here, you need to have a qualified, licensed and trained staff, let it be nurses or doctors. This is not I am saying, this is what is recommended. You need the right kind of infrastructure, make sure that you have a proper connectivity, and then make sure that you have a proper power supply. And your teleconsultation room, first thing is, more than anything else, make the soundproofing. So ambient noise, you need to be very clear about it. And appropriate software. I was talking to IT team here. I said, whatever software, it has to be appropriate. You need to contextualize. Nothing like trying to make a small. come out with a number of things that are there in the available and what a number of things that can be built into application. Then make a modest beginning. But don't try to build something and waste your time and later try to think of adding more and more, because what you need to have is a highway kind of application where you keep on plugging modules. And point of care diagnostics, which Amol will be handling. Attend to security, attend to hygiene, and then make sure the supply chain is strong. And design is one thing. We already spoken something. You can have mobile medical units which can be closed in strategic places. You can try out all these things. And make sure that whatever you do should be operate. You should be able to use it for screening as and when required. And scalability. Scalability is something that Subhajit, you need to be paying attention. So whatever you do, you should keep it in mind that scalability is also attended to. So one thing before, I don't want to lose out, is only around 4 days back, I was into a conference with American Telemedicine Association. Very interestingly, the director, she was talking about, in primary health care, we are looking at 5 points, that's what she said. Improve patient experience, create healthier populations, reduce healthcare costs per capita, improve provider satisfaction. That's where technology comes. And operations come. And ensure affordable access to care. It's not just access. It is affordable access. This is coming from America. Is it relevant in India? You ask yourself. There can be many more. My mantra is do no harm. If you can't, no service denials. You need to consult the last patient. Uniformity of care. The sarpanch comes, you treat him differently, and the laborer comes and all that. Workman comes, you don't different. No. Evidence-based care, there is nothing like I. If it is there, acceptable. It is their algorithm, national level, World Health Organization, or a professional body, American Heart Association. You have to comply with one. And you have to tell yourself and tell everybody, document it and tell them that is what we are doing. We follow these protocols. There is no need to develop any protocols. It is up to you. A number of protocols are available. And positive provider experience, and of course, cost effectiveness. Value for money, whatever money you said. In training, you pay attention to. You train them on technology. One thing in technology, rest of the things anybody can envisage. We found that in our experience that we need to train the nurses, especially video consultation, how far should be the camera before the patient. I should be able to see the patient very clearly. I may not just want to see the face. Sometimes I want to see if the patient is paralytic, has a problem with the skeletal system. I would want to see the patient walking towards me and walking back. In Parkinsonism, we are taught in medical school, the patient turns like a block of wood. If there is a Parkinsonism patient, can I able to, it is a spot diagnosis, right? So, it depends, the technology should be able to support. You need to train them on this one. And the same camera, mind you, there are lots of dynamic factors like pulse, BP, height, even height and weight, and of course other vital parameters. All are dynamic. There is no stable parameter. And same thing we have picture. I was looking smarter than what I am looking now. So other thing is, one of the elderly physician told me, in villages they can't read the prescription. They get confused. 3-4 from the same family. If there is a picture of the patient, you look at the picture, this is my OP ticket. The picture of the child, this is my grandchild's ticket. You bring it there. Otherwise, there is a problem in telemedicine that you may be talking to different patient. Whosoever said. Actually, it happened. The mother-in-law's case was posted, and the daughter-in-law was record was belonged to mother-in-law, and they could have fought unless in case we have not realized. It could have been a real problem. These are all the solutions. I will do one thing. I can share this one, already is there posted and all that. Please go through it, because I feel that you can talk about hours and takes a long time to be able to explain to the granular level. And it is open, and make sure that you collect this one, go through it, and you can use my email and all, and you can feel free to give me a call. Only thing is text me and identify yourself who you are. It's only because of the spam calls that we are getting nowadays. And I think I took a lot of time, but actually I'm supposed to. There are laws related to telemedicine. I think this you can read actually in case. The only issue is, what I would really love to tell you is, please document. You cannot delete anything. It has to go with a timestamp. Whatever observations are made, you cannot delete it. It has to go with a timestamp. Any other laws which are pertaining to healthcare, they have to be relevant to telemedicine. Please go through those things. One thing, Subhajit, please pay attention to clinical establishment. This is where I would stop, because before first teleclinic I opened, I had the opportunity to talk to Health Secretary in Andhra Pradesh. Then he told me, I don't have any kind of document. I don't know how you would want to make sure that you are identified by the government, because you wanted to come out with a model which is not existent. You give us the guidelines. You come out with a draft guidelines. I will share with the government, state government, central government. I will revert you. I am here to support you. You come out with a document. We'll put it to our professional bodies. They will debate. So be sure, make sure. But the thing is, one advice, do one thing what you can do is, give a name to the clinic, list out the number of doctors who are consulting, list out the services that are being offered. That is more than enough. And you need to have the minimum equipment like any clinic would have, any small hospital will have. These are the basic things which you can start. Other things and all that, they will be state specific, especially because health is a prerogative of the state government. So you need to contact the state government and make sure that you talk to the DMHOs. Other things you can just read it now, it is self-explanatory. There were 12, and then I divided them into 3 slides. This is the summary. These are the acts which are relevant, 3 plus 4, around 7 of them, including consumer protection. Don't think that you can get away. And the only thing is that you have proper documentation, you can save your skin. So the regulatory bodies, you have the National Medical Commission. They also spoke about, of course, Ministry of Health. And you have data protection, confidentiality and privacy. And drugs control, state medical councils. These are the guidelines. We can go through it. And there are guidelines for platforms, guidelines for medical doctors. This is a checklist. I suggest please feel free to share that PowerPoint. And this is my last slide. Paying regards to the late Dr. Abdul Kalam. He said, whatever you would want to do at design stage. Otherwise, you are asking for a recipe for disaster. There is nothing like trying to make a modest beginning. You be modest and come with commitment and come with passion and do it. But don't think that you can get away at LKG level. Think of big. Your teleclinic is an intensive care unit. If that explains everything, my job is done. Thank you very much.
Thank you so much, Dr. Sriram. I think it is important for us to understand the basics of this, especially the last few slides. Now I understand why he said this is actually a topic for a longer workshop. It also sets the context for the next presentation, which is how is all this applicable to our teams. So today we have the IT team of Prashanthi Balamandira Trust, who have developed an HMIS and telemedicine platform that the Sai Swasthya and Sai Arogya teams are going to use. And I think it's also, after seeing the presentation, it's a call out to the IT team to recheck with some of these legal acts and all of them that apply, to ensure that even before we start, we are starting at absolutely the right footing of what the statutory norms are with regards to telemedicine. I'd like to invite the IT team to kindly take us through the telemedicine and HMIS app. Request all of you to make notes. Please attentively listen to it, ask questions, because you can't start practicing medicine till you learn the theory. Now you've learned the theory of telemedicine. Now comes the practical side of it. Brother Pala.
Offering my pranams to Sadhguru Sri Madhusudan Sai. My pranams to Swamijis. Respected elders, brothers and sisters, Sai Ram, and very good morning to all of you. So my name is Pala Sitaram. I take care of the central IT for Prashanti Balmandara Trust. Today, as Sister Soumya said, so we are going to talk about the technology solution, the technology platform that is going to support the Sai Swasthya and Sai Arogya program. I'm going to be talking about how this platform came about, a little bit background. Then I have Brother Vinod, who is going to talk about the actual solution. And then we have Brother Pramod, who is going to be talking, who is going to give you a walkthrough of the platform, including the telemedicine feature. So I'm going to start with how and why this platform. So we already had a beautiful, informative presentation from Dr. Sriram on the usage of technology and telemedicine. So I'm going to start with the key requirements, the core requirements based on which this system has been developed, right? So what are the core requirements for a system like this? When we look at the Sai Swasthya and Sai Arogya initiative, if you look at the magnitude of this, imagine 6,000 primary healthcare Sai Swasthya centers and 600 Sai Arogya hospitals, multi-specialty hospitals. So this kind of a gigantic magnanimous initiative. Swami yesterday said this is a game changer in Indian healthcare. So it is going to bring a revolution, Swami said. So to support this kind of a lofty vision of Swami, what kind of platform that we need to develop? So we looked at some of the key requirements based on which, these are the criteria based on which we started implementing the solution. So if you look at, there's a nationwide, program. So we need a single repository of nationwide patient information. Obviously, we need to have all the patient information in one place, right, to start with. We need the system to be accessible from anywhere, right? All of our primary and secondary care facilities. It has to be easy to use. It has to be easy to access by all the doctors and healthcare staff. And if you look at the profiles of the users of this application, it varies from very qualified professionals to the basic users who are registering the patients and the basic things. So it has to cater to all kinds of profiles, user profiles. So it has to be simple to use. It has to be easy to access. More importantly, in fact, most important thing, allow the patient to visit any of our Sai Swasthya and Sai Arogya centers without having to re-register anywhere else. So, once you register, the patient can go with that card, and then our people can get that patient information, the history and everything from the same ecosystem. So that is one of the major criteria. Remote consultation with doctors as needed. as we just saw the requirement of telemedicine, support for local languages. So in order to reach out to the last mile, right, so the last person in every village, we need to speak their language, and the system has to support their language. And looking at the magnitude of this whole system and the platform, the cost of ownership has to be minimum as possible. And so we have already seen any advanced hospital management system, it costs a lot. And imagine providing this kind of a system to every Sai Swasthya center, 6,600 hospitals. So it has to be of low cost. It's a economical but best quality product. It has to be. And we should be able to upload, download patient information, the documents, the reports, and all that. System has to cater to all that. So these are some of the core requirements using which what we looked at, and then based on this, we started looking for a framework and platform, and then we also came up with a design principles. So what are the core design principles? So anyway, to summarize everything, it has to be simple, it has to be accessible, and it has to be secure. Because nowadays, yes, it has to be simple and accessible, but data security is also equally important. And in fact, if you don't know, there are so many data breaches happening in the healthcare industry today, and it is costing billions and billions of dollars to the organizations. So we need to ensure that the data security is maintained. So based on the requirements, the design principles that we came up with. So we need to use the cloud technology. Again, I don't go too much technical into this, but cloud technology is something where our application runs on internet and you can access it from anywhere. It is not that application runs in our hospital facility or hospital premises. So it is going to run on internet so that you can access the information, you can access the application from anywhere. One single source of patient information, seamless patient experience between any Sai Swasthya or Sai Arogya centers, multi-language support. Basically, we are representing the same requirements in technological terms. Teleconsultation capabilities. So what we have done is we have integrated Google Meet as a teleconsultation platform, which is integrated within this application, so that click of a button, it will initiate a session, and then the patient and doctor communication can happen. You will see it shortly now. And most importantly, we need to use an efficient, lightweight, and open source framework. Obviously, open source is something which is available freely, which is developed by an open community. So this framework what we have selected is an open source framework, which cater to all the requirements that we have had. And most importantly, Dr. Sriram also talked about it, scalable architecture. So we have, as we are seeing now, the Sai Swasthya centers are coming up one by one after the other, right? Every other day, Sadhguru is starting a new Sai Swasthya center. So in order to be able to support this, we should be able to, the platform should be able to, create this center record in no time, and we should be able to get going and start using the system on day one. So that is the scalability, and then cater to the big number of patients. And eventually, we will have millions and millions of patient records supported by the system. Ensure security for data storage and data access, and efficient file management capability. So these are the design principles on which our system is being developed now. So like a very quick high-level view of how this thing works. So the Sai Swasthya, Sai Arogya Cloud HIMS is what, so that is how we are representing this platform. And you can see that all the Sai Swasthya centers and Sai Arogya hospitals are supported by the same platform. And we just saw the telemedicine requirement. So how the platform supports is we have a telemedicine module built into the platform. And at the Sai Swasthya center, So there is teleconsultation equipment provided, and the nurse who is manning the Sai Swasthya Center will be initiating that session with the patient sitting in front of the screen, and then it connects to the doctor in Sai Arogya Hospital, or it can connect to any doctor which we have, whom we have already pre-selected. So they can speak to any doctor anywhere, and then do the teleconsultation. So I mean, this is just very simple, put it very simply, but there is a very complicated infrastructure behind it. But yeah, so it makes it very simple for the end users. And I also wanted to put in perspective where this initiative stands in Sadhguru's the global vision, the global healthcare mission. So if you see, the Sai Swasthya, Sai Arogya is part of the primary and secondary healthcare services in Sadhguru's mission. And we also have the tertiary hospitals, not only in India, but over so many countries. We have multiple regions, North America, Europe, Asia, and Africa. So all the tertiary care hospitals eventually will be coming onto this platform, so that we have one Sri Madhusudan Sai Global Humanitarian Mission Healthcare Information Repository on cloud. So this is the grand vision that Sadhguru has given us. So eventually we will be reaching this stage. I also want to bring your attention to how the IT is going to support this entire initiative. On one side, we have the hospital management system platform on the internet, and if you see the all the region-wise Sai Swasthya centers and Sai Arogya, they are all supported by multiple trusts. So it is not that just one trust or one entity supporting all these facilities. So there are multiple trusts who are going to be supporting in different regions. So the platform has to support all of them, and we also have a cloud-based donor management system which is going to support all the trusts, so that they can manage all the donations and the funds coming raised for conducting the service initiatives. So eventually our system basically is going to be supporting all cloud-based systems, supporting all this on one side, the medical side, and then non-medical, the administrative support also will be given by the platform. And then at the bottom we have listed all the websites. So websites will provide links to the cloud-based donor management system which will be used by the trust administrations, and to support all the Sai Swasthya, Sai Arogya centers, and which are in turn supported by the HIMS platform. So this is like a very high-level picture of where we stand. And another thing that I want to draw your attention to is how we have coded or how we are going to be coding the Sai Swasthya centers and Sai Arogya centers. So each center will be given a unique code and unique identifier. It could be completely numeric, or we also have come up with alphanumeric codes. When I say that, for example, for Bapatla Sai Arogya Center, SABAP will be the center code. And all the patients registered in that center, the patient registration number will start from SABAP, then there's a numeric format based on the year of registration and things like that. So we can uniquely identify a patient just by looking at the registration number. We also know where this patient got registered, which year the registration happened. So we have come up with a very unique way of identifying that and the registration formats. So we are going to use that in this global platform. So that is going to help us really identify the patient uniquely as soon as we see the patient registration number. So we will also show you that when we are going to demo the system. So now I would like to call upon Brother Vinod, who is going to talk about the FRAPPE framework that we are going to use, or we are using to build this solution. So Brother Vinod heads the Tech Unison India operations. So it's a company called Tech Unison, based in Coimbatore, Tamil Nadu. And Brother Ramesh Dharmaraj, who is running this company, Tech Unison, in the US and in India, He's a great devotee of Swami as well as a great supporter of the mission. So Brother Vinod heads their India operations, and they are the ones who are helping us develop this platform. So I'll call upon Brother Vinod to quickly take us through this Frappe framework. The next slide you can put.
Good morning, everyone. So I would like to touch upon the framework which we choose to build our HIMS software, which helps and reduce the time for doctor to capture the data, because we always value how much time we have to spend should be more on the patient-centric rather than just a data entry system, okay? So while we evaluate this framework, right, the first thing we saw is like, if you see, right, it should be easily accessible from anywhere, okay? And also it should be highly secured, and the data has to be scalable, okay? So these three key things we just initially taken upon the initiative, and then we also made a easily form customization. So this one I just want to go in depth, okay? So the reason we choose this is, right, so every department, right, you have a different kind of templates and observations, like the ophthalmology, cardiology, and any department. So it should not be a generic form where we need a technology team you have to sit with the technology team and then tell them that these are the observations I need to capture, because each doctor has its own way of doing that, okay? So what we did is like we identified a framework that can be easily just a drag and drop, build a form, and whatever the fields you want, you can able to make it customizable and then easily accessible, okay? So that is the key thing we have reason behind we choose this Frappe framework. And the Frappe framework is a very proven concept. I think everybody knows Zerodha, a trading platform, right? So that is used by this platform, Frappe framework. So it can be scalable, and since it handles n number of financial data, this can capable of handles the secured hospital data also, okay? So it's a very proven one, okay? And it is very low cost also. There is no vendor lock-in here. So basically when it comes to software, right, most of the time to integrate with something, right, we need a third-party licensing fee, user-based licensing, database licensing. There are a lot of things are there. So everything gets rid of using this Frappe framework. So Frappe is just a software piece of framework. We used that, and then we built on top of it whatever the customization we want, okay? And another thing is like whatever the form we built, right, it is API ready. So API ready in the sense, in the layman term which we can speak, is like it's easily integratable with any system. Say for example, in one of the hospital, Baptala, we have integrated with PAC system. So where you can able to see all the X-rays, scans, CT scans, everything in the system itself, okay? So it is easily integratable, and also it is easily scalable with other systems. Like for telemedicine, right, we were thinking of building our own custom solutions. But if you see, like in actual scenarios, every doctors will have mostly Google Meet, right? So we just make use of the Google Meet as a telecommunication rather than we building it on our own. So we just used this API, and then we integrated with the Google Meet, so that it will be very easy for doctors just to even do telecommunication using a mobile or tab, okay? You no need to have a system also. So it is on the go, easy to customization. And other things are like it is patient-centric. So patient-centric in the sense, like if you are doing any encounter, right, you can see the entire history in a single page. So all the pages are getting linked to a single page. So since it is form-based, right, so it is getting linked, so that you can see every history and every visits, everything in a single page, okay? That is one advantage here. And the reports and dashboards, right? So dashboard, however the dashboard you want, based on the data you captured in the customized form, you can build your own dashboard. So you no need to ask a developer and then do it. So basically nowadays, after AI comes, right, the trend comes called low code. So you can just drag and drop whatever the data I want, and then you can able to drill down the data and then go see everything, okay? So you can customize your own data, own dashboards. That is one key advantage here. And other thing is like roles and permissions. So roles and permissions are inbuilt in this framework, okay? At a field level, roles and permission, who has to see this record, who has to not to see this record, you can customize it on your own. So if you train it, if we able to train with you, sit and for 30 minutes, right? You can itself create your own things like nurse, what they have to do, what workflows they have to do, and what fields they can able to capture the details, and what you want to make it more secure, and then you want to see the data. So everything is role-based. So this is the reason behind we choose this framework. Okay. So I think that's all it is about technical things. So I think I would like to give a mic to Pramod brother. He will show you about the telemedicine and then the overview of the application. Okay. Thank you.
Hello. Saram everyone. Seeking blessings of Sadguru Sri Madhusudan Sai, seeking the blessings of Paramapujya Swamiji. I would like to now give a walkthrough of the complete HMS module. So I would like to make it more lively, more interactive, wherein we get the inputs from the audience and then we see what best can be incorporated in the system. First, I would like to ask the questions, since there are doctors, healthcare workers. How many of you would like to use the systems than pen and paper? So compared to the audience, the percentage of the hands that's going up is less, and the hands that are down is more. Because what we have observed is doctors are more comfortable putting it on their prescription slip. It is easy to do. Then why do we need the system? What is the need for the system? See, in this age of AI, artificial intelligence coming in, we all know, right? Whatever we want, we just give a command to ChatGPT. ChatGPT, correct my grammar, it corrects our grammar. ChatGPT, give me a list of this, it gives us the list of this. Sir was talking about ICD codes. ChatGPT, give me all the ICD codes, it gives us the list of all the ICD codes. So the logarithms are evolving in such a way that observing the patterns of how the diagnosis is made, what is the symptoms of the patient, we will be able to tell which medication should be prescribed to the patient, which investigation should be ordered for this particular patient, which drug should be prescribed for the patient, which radiology investigation needs to be done. So the technology is improving in a rapid pace. Now, how do we adopt to the technology? The technology works based upon the modeling that we have provided. So if I want to take an example of the recent ongoings that is happening between Gaza and the war, right? So there was an article in the newspaper where it said, reading the chats that were happening, the WhatsApp chats that was happening with the people there, the AI was able to tell where the next strike is going to happen. So that is how integrated the technology is. Then how is it going to happen? If we gather the data in a structured format. Now, if all of my data is there on a prescription slip, how can I even model what drug has to be ordered to the patient? So the information technology is evolving more and more, and for that we need to adopt, and what are all the measures that we need to incorporate is we need to structure our data, and that is the need for information, and that is the need of the hour now, and that is the reason why we are shifting from a traditional writing on the prescription slip to a system. And the frappe coming in, right? And now that how we operate is, we as engineers, we want to give a system that doctors want to use. So we don't put ourselves into doctor's shoes. What will be the doctor's mindset? What will be the, how the doctor wants the screen to be designed? So the frappe framework, as it's more flexible, it has the API endpoints, So for each doctor, we can customize the screen. For pediatric doctors, we can customize the screen as they need it. For OBG doctor, we can customize the screen as they need it. And general medicine doctor, we can customize the screen as they need it. And this is completely open source. I'll talk a bit about open source. So we are all speaking about open source, open source, open source. What is this open source? See, usually how the software development happens is 10 engineers get together and they develop a code and they restrict within themselves, so that code we can sell it off. Now the Microsoft licensing, all of this licensing that we pay, right? They are all license based. So that is like a group of engineers have come together, developed a platform, and that they are selling for price. Now this open source is something like group of engineers come together, they open the code to the public. The community will interfere and say that this change has to be done for this particular application. And let's say now we are using this Frappe technologies. Now we say for our chain of hospitals, for our architecture of hospitals, we have tweaked the code in so and so way. So we go to the forum and say that this is our tertiary care of model, the primary care, the secondary care, the tertiary care. So the 3 cares of model, and this is how we have adopted the system. Then there might be some other NGO that is in Europe, some other NGO that is in US, they would come up and collaborate with us saying, oh, we can adopt your code. So this is more of, we are not restricting the code to ourselves, so we are releasing it to the public will support in turn. So the Android that we all use, right, they are all open source. So we can customize how we want our own screens. So a bit about open source. Now I'll quickly run through a high level view of how the system is defined and the patient registration, how it happens. From the patient registration, once the patient is registered, then how do we give the appointment, and once the appointment is given, how the nurse captures the vitals, and then the doctor consultation. So post this, we will have a tea break and then come back for the teleconsultation. In the teleconsultation, we will actually demonstrate live how the teleconsultation happens in the Sai Swasthya Center. So right from how the nurse also has to do the teleconsultation, all the best practice measures. So we are going to demonstrate it live here. And now we'll quickly run through how the system is designed. So this will be the landing page when any user logs into the system. So it will have a metrics of, these are all the dashboards that we can customize for ourselves. There, how many patient appointments have happened. So if we see the spike, right? So then on that particular 13th day, there was a spike in the patient appointments. So this is more for the administration team to take care of why on this particular day the appointments have gone up, on the other day the appointments have come down. So this is all on our own hands. We can take the metrics, we can customize the graphs for ourselves and make a good look and feel. So we'll start with the patient registration. We'll go to the patient registration screen. Can you reduce the video there in the top corner? Yeah. So this is the patient registration screen. The patient registration activity will be done by the front desk people. The front desk person, once he'll have access only for registering a patient and giving appointment to the patient. So they'll click on add patient. When a new patient comes, they'll register a patient and then give the appointment. Go to the top. So here we have sections called details, medical history and barcode. So for any new patient that comes in, we'll capture the details and then the past history, if they have any medical history they have, we'll capture that, and then the barcode, that is for the each identification of each patient, unique patient. So the center is like Sai Arogya Hospital, Bapatla. We have in the same platform, we have different centers. All our Sai Swasthya and Sai Arogya centers will be on the same platform. So for this Bapatla Hospital, we are registering the patient. And then we'll capture the first name, last name, gender, date of birth, age, Aadhaar. We have made it as mandatory because now most of the people in India have Aadhaar, that we have made it as a mandatory. But in consultation with the management, we have also found that in so many of the rural areas, there are patients who are coming without Aadhaar. So we have given a privileged user for one person in each of the facility where they can register the patient without Aadhaar, but then they will instruct the patient that next time when you come up, please bring Aadhaar. Why are we doing this? So now we talk about this Ayushman Bharat integration with the ABDM, right? So if we have this, if we want to push our data to the ABDM portals, there is steps called M1, M2, M3 integrations. So for doing all of that, we'll have to have unique registration of the patient. Pramod going into Bapatla hospital today and Pramod going into Bapatla hospital day after tomorrow should not have two different records. So if Pramod goes back to the Bapatla hospital day after tomorrow and he gives his Aadhaar and the front desk person goes on registering a patient, it should say that Pramod is already there in the system, please use the existing record. So Aadhaar we have made it as mandatory, and we have also given an option of overriding the Aadhaar and proceeding with registration. And then we have a mobile number that is kept as mandatory, and email ID also. Email ID is not mandatory. If the email ID the patient gives, we can enter it here. We have an option of invite as user. What does this invite as user means? So if the patient gives us the email ID, right, then we'll send out a link to the patient so that they can view all their diagnostic reports, all the prescriptions on their own in their mobile, in their laptop from their home. So it's like we are giving access to this system for their record. And then if there are any other patient details, specific details that needs to be captured, we'll capture it. This is completely a free text. We'll go to any of the registered patient. Please connect the laptop to the charger. Laptop to the charger. So this is one of the registered patient. So we'll have all the details that has been registered, and I would like to bring to your notice one unique coding method that we have used, the UID, SSVTH. So here if you see, right, SS, that means Sai Swasthya. Can we shift to the Excel sheet? Yes. So Sadhguru has given a vision of 6,000 Sai Swasthya centers, 600 Sai Arogya hospitals, and then the tertiary care hospitals in every state. Now, how do we register a patient based upon the center wise? If we have one record, right, one centralized directory where all the patient gets registered into one center, then over the time, if there are, let's say, 10 lakhs patient, then searching each patient becomes difficult. So we have come up with a unique coding system based upon the centers that we have. So for example, these are all the centers that are there in the Karnataka, the Sai Swasthya centers. So Vatada Vasalli is one Sai Swasthya center name. So SS, that means Sai Swasthya, and then VTH. Vatada Vasalli center will have VTH. All the patient that gets registered under Sai Swasthya Vatada Vasalli center will have the UID, that is the patient unique identification number starting with SSVTH. And then they will have the address of 25. 25 will be the year in which they are getting registered. Yeah, SSVTH. 25 is the year. If they are getting registered next year, it will be 26. Then the series of 6 digits. So wherein we can, for each center, we can register 9,99,999 patients. So that is the coding system that we have used. So this will be there for all the Sai Swasthya centers, and let's shift to the Excel sheet. Come to the Andhra Pradesh region, the second sheet. Yeah. So here if you see, one is Vizag is a Sai Swasthya center. It will have SS, Sai Swasthya VZG, Vizag. But whereas Bapatla center is a Sai Arogya hospital. So it is a SABAP. So the patient getting registered under Bapatla hospital will have a patient ID of SABAP 25, the year in which they are getting registered, and then the series. Let's come back to the system. Telangana, go to the Telangana. So we have Kagaznagar and Jagatihal. Sorry? Sorry? Yeah, the third center is there. So once we get the list, right, so currently these two centers we have got the list and we have mapped in the system. So as and when the Sai Swasthya centers gets adding, we will get the request from the respective team and then we'll add it into the system. Let's go to the West Bengal. Yeah, here the Sundarban region has come up as a new request. So we are going to have a code for that and feed it into the system. So similarly, we have Odisha, Bihar, all the Sai Swasthya centers that are there in each of the states. Yeah, let's shift to the system. And then this is the patient, registered patient. Here we have an option of actually attaching the photo of the patient and then any attachments. Let's say the patient has come to our center with few of the previous health records, with some of his lab records of that was getting done in the previous consultation. So that we can attach against the patient record here. Attachments, and we can also click a photo and attach to his profile. So the address, contact and medical history will be there against each patient. We'll go to the appointment screen. So now that the patient is registered in the system, the front desk person will give appointment against a doctor for consultation. So here they'll click on the add appointment. And what will be the appointment type? It will be doctor consultation. And who is the practitioner? So these are all the practitioners that we have for the Bapatla center. We'll give appointment to one doctor. Let's select any doctor. And the patient will select the patient which we just showed. Yeah. And then we'll go for check availability. Check availability actually shows how many slots or does the slot that is there for the doctor is booked or it is empty for carrying out the consultations. So for Dr. Manideep, we have 15 slots each, right from 9 o'clock to 2:30 in the afternoon. And this 10, whatever you are seeing is, this is a customizable thing wherein in that slot, how many consultations the doctor will be able to do. So we have seen cases wherein some general medicine doctor, they will be doing around 20, 25, 30 consultations. So if we give 15-minute slots, then hardly we can book some 15 to 20 consultations. So we have given maximum how many consultation can be done in each slot. So this 10 is just a random number. This can be customized. So if it is 2, let's say it is 2 and at 9 o'clock we book one appointment now. In the next booking it will show at 9 o'clock 1. That means only one slot is available and then that slot is booked. After that it will be grayed out. At 9 o'clock there cannot be any more appointments. Yeah. So now the appointment is booked. So if you see, it is saying as scheduled. If it was for today on 18/5/2025 itself, it would have said open. So it is open for consultation today. But whereas it is scheduled for some other day, it is scheduled for 19. Because for the 18th, we don't have any slots available for that particular doctor since it's a week off. We'll go to any of the patient appointment and come to the vitals capture screen. So vital capture, once the appointment is given to the patient to a doctor, now the patient will go to the lobby, wait for some time, and then the nurse who is responsible for capturing the vitals of that particular patient will capture all the vital records and key it into the system. Go to the vital signs. So against this patient, for this particular appointment, we are capturing all the vitals. Vitals options we have of body temperature, and then the heart rate or the pulse rate, respiratory rate, and then we have blood pressure, systolic blood pressure, diastolic blood pressure, and then what is the condition of the tongue and how the abdomen is. Can we expand the drop downs? What all drop downs we have in tongue? So what is the condition of the tongue? and then the abdomen. So these are all the drop downs that is again customizable by the, so the admin who has access to administrative credentials for that particular center will be able to configure what and all drop downs should be available in each of these text box. Then the nutritional values, height, weight. So once we enter the height and weight, the BMI gets auto calculated. And it also says whether he is a overweight, underweight or normal. Let's save and proceed. Now we'll go for the patient encounter. What is patient encounter? Now the appointment. Yeah.
Can a nurse can assess those vitals correctly, do you think? Condition of the abdomen
Mm-hmm.
and all those things via the vitals. They can record height, weight, BP, all those things, temperature, I can understand.
Mm-hmm.
But when a nurse is capable of doing all these things, what you have written there, vitals.
Yeah. So the system, this is a by default the functionality that is available in the system. Now, if we say that our nurses are not equipped enough to capture those vitals, so it is a non-mandatory field. So they can skip those two fields and enter the other fields like height, weight, and the BP, sugar, and proceed to the system. So those are non-mandatory fields. It's not mandatory that they should enter this and then save this one. That can be assessed even by the doctor as well. So the doctor also has a privilege of editing this particular vitals record. We'll come back to the patient encounters. Not mandatory. I mean, currently it is mandatory, but we also have a privilege of overriding the Aadhaar card mandatory and proceeding. Okay. Sure. So we'll work with the team, and we'll consult the Telangana representative who is there. So then we'll remove that field for the Telangana region. And the patient appointment will, what does patient encounter mean? The appointment has been scheduled for 9 o'clock now, or 11 o'clock. Now the doctor asks the patient to get into the consultation room and starts assessing the patient. So patient encounter means the patient is in front of the doctor, and the doctor is assessing the patient, keying the information into the system. So by default, all the patient details appears in the top, and then the allergies and medical history, what the front desk person would have entered appears here, or even if the doctor entered the allergies and the medical history of a patient, this will be available for all the doctors to view. Let's come down. And then the visit details. Visit details is exclusively for this particular visit. At this point in time, what is the chief complaint, what is the comorbidity, and what examination they are going to do, history of present illness. And then we have diagnosis. So sir was telling about the ICD codes. Now we have integrated the system with ICD-11 coding standards, ICD-11. So now you can either key it into the system with the ICD code or just type the symptoms. Let's say typhoid. Typhoid, just type typhoid. Yeah. So all the applicable ICD codes related to the typhoid appears. So the doctor will select here. Let's say some other fever. So we have integrated the ICD-11, they have exposed their API, it is publicly available. Sorry? In the ICD code? Yeah, so it comes directly from the ICD-11. Take it to typhoid. Typhoid. Yeah, so typhoid, that code here, sir. So this is tightly integrated with the API that is exposed by the forum. So every time we hit any keyword, it hits the API there and fetches back the result. Yeah. And we have a doctor fields, doctor notes, which is a free text. So the doctor will enter the doctor's notes. And here we have the investigations. Click on add row. So all the investigations, the lab tests that we conduct in any of the center will be listed down here. Let's say complete blood count. So you can add another row. Now for the patient, we want to add complete blood count and TFT, thyroid function test, and lipid profile, thyroid function test, TFT. Yeah. So they can add row and add as many investigations that needs to be conducted for the patient. Let's come to the, similarly we have the radiology section. So in the system for the Bapatla hospital, we have only the X-ray and the ultrasound. So that's why in the system we have loaded only ultrasound and the X-ray. All the service items, that means the investigations that we do in X-ray and ultrasound will be listed against each of that. Let's select ultrasound. And go to schedule procedures. Yeah. Type as USG abdomen. So it will list down all the service items that we have captured for, that we have configured for abdomen, USG abdomen, pelvis, UFG abdomen. I mean, these are all the inputs that are given.
In the X-ray, if I want X-ray chest, how do you go?
Add another row. Select X-ray. Yeah. So modality is like which modality? Ultrasound, CT, MRI. So we select the modality first. Then all the service items for that modality lists down here. Just type X-ray chest. X-ray chest AP. Hold on. We'll see all the drop downs. So all the X-ray chest different views that are available, we have put it up in the system.
X-ray chest usually PA view is preferable.
Okay. Yeah. So this is all the items that we have configured in the system currently. Yeah. So then we'll go down. So if there are any procedures that we are conducting in the hospital, we'll add it in the procedure section, then the rehabilitation, medication section, add medications. Let's say Dolo 650. So again, the request from the doctors usually is we want both the brand names as well as the generic names. So the system is capable of putting both. It's just that as a pharmacy, we'll have to maintain both of the brand names mapped against the generic names. So then by typing the generic names, also the medication, that particular tablet lists down here, or by typing the brand name also, the medication lists down here. The dosage. So this is again configurable at the time of entering also. If you see that the dosage list that has been listed down here is not sufficient for us, you can create our own. And then the period for how many days this tablet has to be taken by the patient. Let's say 1 week. Yeah, 1 day.
So why do you want to use the brand names?
So, I mean,
That you are not going to be compliant with Ayushman Bharat. No, the orders are very clear. You have to be writing
with
name
the
of the
generic
molecule.
names. With the generic names.
It's not an NHM. The prescription guideline as per the act is also says that you have to use only the generic name.
Generic names. Okay.
So it is prefer, at least let's just you prefer to have a generic name as in your identifier and then come as a brand name side by. But,
Okay.
yeah.
Separate column for the brand.
It has to be the molecule.
Okay. Okay. Sure. We'll make a note of this. We'll implement it in the system. And then we have, sorry, yeah. Can we get the mic there?
I would like to answer this, sir. I have been using this software since the past 2 years. The software which I am using, we have an option to give a prescription, generic prescription as well as trade name prescription. Both can be incorporated. Like if it is Dolo 650, in brackets it will be there paracetamol 650. Trade names, why it is important is when this prescription goes to the pharmacist should be able to understand what drug he is supposed to give. If we give generic, most of the pharmacists might not be aware of the trade names that are available with the pharmacy. So when giving printout, we can choose whether to give generic or a trade name. And if we give this prescription, they can go outside also and procure the drug. Thank you.
Government of India
Yes, sir.
that you have to go only on a generic name. If you go on a brand name, that means what you are doing, you are personally favoring a particular brand.
Yes, sir,
and then
that's
again-
right.
So that's why you should not give, as a doctor, you should not give any prescription with a brand name.
Yes, sir. That's what. But for the convenience of the local, suppose my drugs go like this, whatever software we are using, my pharmacist will get the same prescription. When the trade name is there, it's easy for him to identify the drugs. But when we are giving the prescription printout outside, it will be, we can actually, we can choose whether we should give the generic form only or trade. So we will, this way we'll be complying with the rules also. Thank you.
I agree with you. There's, for example, if you write paracetamol 650 milligrams, in the next column, in the box, you can come out with what, in case you prefer to have the brands. The thing is, your prescription by default has to have the molecule name. I'm not getting confused between a generic drug and a molecule. I insist that I will call it a molecule because generic drugs and then brand drugs are different, they are commercial. For example, most of these multinationals, they have brand and they also have generic. It is up to you. And then that's how most of the medical shops make money. The actual brand name, for example, if you prescribe rabeprazole, it is around 15 rupees per tablet, the brand. The generic rabeprazole from same company, it is available for 10 rupees.
So,
No, the thing is, that's the reason I said the rules are very clear. Of course, it is going to take, I think, more than a decade to practice and to drive it into the minds of pharmacy as well as medical personnel. The idea is to prescribe the molecule.
sure.
For example, if you are prescribing iron, these things, a different kind of these things are used for different kinds of contexts. You can use a sulfate, you can use a fumarate.
Yeah. Do the generics have?
What I heard, generics have no quality control in the generic. Do the generics have quality control?
The pharmacy.
That's what I heard. Generics have no quality control in the factories. That's what I heard from the representatives.
Sir, or what we can do is to answer your question if we want to.
Sometimes that's why we prefer to give.
Correct.
She will have, because the problem with the pharmacy is that
Correct.
you can't change the formula.
Correct.
But make sure that you have this one. Next to that, then she can choose.
Sure,
For
sure.
example, she can write 06.
Got it. So we can have two separate boxes wherein we'll first write the generic names. So then all the brands that we have in our pharmacy for that particular generic drug, then that will list down. So for example, paracetamol if we give as a generic name, then Dolo 650, Crocin, all of that will come up as a brand names, the brand that we have.
Give that and also make sure that you can give the availability.
Yeah. What is the count of the?
650 is now available, Crocin 650 is available.
Yeah.
Her choice, she will make a choice.
Got it. Madam, to answer your question, so we have come up, what we are saying is we'll have the generic names. Got it, yeah. Yeah. I mean, I am an engineer, so so you use the medical term I use.
You are a technology guy. You are a technical.
Yeah, let's come back to the system. Sorry, there was one more question. Yeah. Can we get the mic over there? Sure. Yeah.
So the main problem where only using the molecule name is because you have pharmacy integration in this.
Yeah.
So I'm using some other platform so I can give an insight into it. So when we use only the molecule name, and it goes to your pharmacy. The pharmacy is integrated, right?
Yeah.
So then there are 5-6 brands with the same molecule, and you have batch-wise data what are available. So you cannot back integrate it what the pharmacist is giving and what is the availability you have. So it is always better to have the molecule name and the brand also in the prescription, so that in the drop down we will know what molecules are available and what brands are available.
Sure.
And in pharmacy integration, because they have batch-wise data,
Yeah.
you should know what batch drug you are giving.
So, and in this system, it's also back integration is also done, wherein let's say there are 500 crocins now and we dispense 10 crocins. The next time the doctor is ordering, it will show 490 is the current quantity. So order accordingly.
So if you
Yeah.
don't have the brand name, only
Yeah.
molecule name,
Got
what
it.
batch you are giving is not possible.
Sure, yeah. So in the interest of time, we'll take the questions when we are in the tea break later, and we'll complete this one patient encounter workflow and we'll close this. Let's come back to the screen, complete it. Screen. So then the medication is ordered, then the doctors write the patient summary and the follow-up details if needs to be done any, and saves the encounter. So once the doctor saves this encounter, the lab workflow, the radiology workflow and the pharmacy workflow will be auto-triggered. That means the lab technician will be able to see what investigation has to be done for this particular patient. Radiology person will be able to see what investigation has to be done for this patient. So by the time the patient goes to the pharmacy counter, the pharmacy person will know what and all medications needs to be dispersed for this particular patient. So all the three workflow will be simultaneously triggered. So this is just a quick overview of the system. So for each of the team, we will connect virtually or in person when we visit the center, and we'll give a complete walkthrough. If there are any questions, we'll always be available here in Muddenahalli, which we can connect or virtually, and we can answer your questions. So post this, we have a session of the teleconsultation, which will be happening live here. There will be one doctor who will be taking the consultation from the consultation room in the same block, and we'll have a live consultation that is happening here for 15 to 20 minutes. Yeah, thank you.
I'm specifically asking about the Bapatla Center. Whatever the equipment that we have, suppose we don't have the specialists on site. So like ECG or ultrasound or chest X-ray or whatever the investigations that we have, do we have the capability through our software to send it out to a specialist on his phone, or if it is images, or if on the phone or something,
Yeah.
so that we can get the feedback immediately?
Sure.
Is it possible?
Yeah. So it's like we can either give a printout of this prescription slip where they can get the investigation done outside, or if we have a collaborative approach, the system that the outside or the outsource center is using. So we can send this information to that outsource, what are the system that they are using. So the APIs are available in this system. That means the endpoints are available in this system. It can be tightly integrated.
And if they don't have any specific system, suppose can you send those images on my cell phone?
Yeah, that is possible. So once we have that collaborative approach, then we key that person's name into the system, the WhatsApp number or the email ID, and that can be dispersed over the.
And also, can we do it the live, like taking any EKG, ECG, the live picture? Can we send it, or ultrasound? Can we send the live pictures?
So we have the PAC system integrated to this software. So their PAC system, what they are using, so they'll also have a PAC software if they are using any of the ultrasound machines. So if they are ready to expose their images to us, then we can establish a connection between the two systems.
You have to have the PACs other side also.
Yeah, in short, it is yes.
Not on the cell phone. You can't send it on the cell phone. Without, if they suppose if they don't have if the other side doesn't have the PAC system, is it possible to send it to?
So one thing what we came across while implementing the software here is there was a request that we want to view the radiology images in our cell phones or in our system in the home. Then there were doctors, the HOD came in and told that it is not as per the compliance. All the radiology images has to be viewed within the center itself. The doctor has to come to the hospital and view the radiology images. It should not be available outside of our network. So it's like we can restrict it and give them the access.
I think the images can be sent outside whomever we have a contact.
Yeah, so if we establish a tunnel for sending the images, we can. Yeah. So we'll take the questions when we are having a tea, and we'll break for the tea. Thank you.
Have the presentation on the telemedicine module, post which we will have the demo of the point of care tools.
Yeah. ನೀವು ಬನ್ನಿ, ನೀವು ಆ ಕಡೆ ಕೂತ್ಕೊಳ್ಳಿ. ಹಿಂಗೆ ಕೂತ್ಕೊಳ್ಳಿ ನೀವು ಅಷ್ಟೇ.
మాట్లాడిన ఇంపార్టెంట్
ಫಸ್ಟ್ ಇನ್ನೊಂದು ಸ್ಕ್ರೀನ್ ಬರಬೇಕು. ಇದಲ್ಲ. Yeah, we are good. Good morning, everyone. Welcome back. So now we'll have a short presentation for 10 minutes. The live presentation as to how the teleconsultation is going to happen with the new Frappe environment. And here, right from capturing the vitals, we'll show how we navigate in the system and capture the vitals in the system, and then how we connect with the doctor remotely. Can we have the feed of the system? So now for patient Gopinath, the tele appointment has been booked to Dr. Ranjini. Dr. Ranjini is seated in our facility here in this hospital in the second floor, where we have the teleconsultation rooms. So here, if you see at the top, there is a button called teleconsultation. Now it's just that the nurse who is there in the Sai Swasthya Center has to book an appointment for the patient and then click on this teleconsultation. So even before joining with the doctor, she'll capture the vitals and enter the vital details into the patient profile. So we'll go to the vitals section and capture the details. So usually in our Sai Swasthya centers, we'll have the body temperature, the weight, height, and all the other details that Shilpa will explain what and all they capture in the Sai Swasthya centers.
2 days in the ಮೈಕೈ ಎಲ್ಲ ನೋವಿದೆ.
2 days ಇಂದ ಮೈಕೈ ನೋವು. ಜ್ವರ ಎಷ್ಟು ದಿನದಿಂದ ಇದೆ?
2 ದಿನದಿಂದ ಇದೆ.
ಇದಕ್ಕೆ ಮುಂಚೆ ಎಲ್ಲಾದರೂ ತೋರಿಸಿದ್ರಾ ನೀವು?
ಇಲ್ಲ ತೋರಿಸಿಲ್ಲ, ಇದು ಫಸ್ಟ್ ಟೈಮ್ ಬರ್ತಾ.
ಟ್ಯಾಬ್ಲೆಟ್ಸ್ ಏನು ತಗೊಂಡಿಲ್ವಾ?
ಟ್ಯಾಬ್ಲೆಟ್ಸ್ ಡೋಲೋ ತಗೊಂಡಿದ್ದೆ, ಕಡಿಮೆ ಆಗಲಿಲ್ಲ.
ಓಕೆ.
ಜ್ವರ ಇದೆ.
ಬಿ ಪಿ ಶುಗರು ಏನಾದರೂ ಇದೆಯಾ?
ಇದೆ ಬಿ ಪಿ ಇದೆ ಸ್ವಲ್ಪ.
ಟ್ಯಾಬ್ಲೆಟ್ಸ್ ತಿಂತಾ ಇದ್ದೀರಾ?
ಟ್ಯಾಬ್ಲೆಟ್ಸ್ ತಿಂತೀವಿ.
ತಿಂತಾ ಇಲ್ಲ. ಮತ್ತು ಇದೆ ಅಂತ ಹೆಂಗೆ ಫೈಂಡ್ ಔಟ್ ಮಾಡಿದ್ದೀರಾ?
ಅಂದರೆ ಲಾಸ್ಟ್ ಒಂದು ಸಲ ಚೆಕ್ ಮಾಡಿದ್ದು ನಾನು.
ಓಕೆ.
ಸ್ವಲ್ಪ ಇತ್ತು.
ನಿಮ್ಮ ಫ್ಯಾಮಿಲಿಯಲ್ಲಿ ಫಾದರ್ಗೆ ಮದರ್ಗೆ ಬಿ ಪಿ ಶುಗರ್ ಆ ರೀತಿ ಏನಾದರೂ ಇದೆಯಾ?
ಅಪ್ಪ ಅಮ್ಮನಿಗಿದೆ, ಅವರು ಏಜ್ಡ್ ಆಗಿದೆ.
ಓಕೆ. ಅವರು ರೆಗ್ಯುಲರಾಗಿ ಟ್ಯಾಬ್ಲೆಟ್ಸ್ ಯೂಸ್ ಮಾಡ್ತಾ ಇದ್ದಾರಾ?
ಟ್ಯಾಬ್ಲೆಟ್ಸ್ ಯೂಸ್ ಮಾಡ್ತೀನಿ.
ಓಕೆ. ವೈಟಲ್ಸ್ ಚೆಕ್ ಮಾಡ್ತೀನಿ.
So in the interest of people who do not understand Kannada, so what conversation that happened between nurse Shilpa and the patient Gopinath is, so patient Gopinath had a fever and nurse Shilpa actually asked, what are all the symptoms that you have? Do you have a past history of BP within your family? Do you have sugar? Do you have past history of sugar within your family? And she also asked, what is that you feel, whether you feel high temperature? And so now Shilpa has decided that to measure all the parameters of patient Gopinath, and she'll be capturing the BP, sugar, and height, weight of patient Gopinath. So now the capturing of the BP has happened, and Sister Shilpa is now going to key it into the system. Can we have the screen sharing of the system input?
ಫೀವರ್ ಬರ್ತಾ ಇದೆ.
ಜ್ವರ ಎಷ್ಟಿದೆ ಅಂತ ಚೆಕ್ ಮಾಡ್ತೀವಿ. ಮಿಷಿನ್ ಅಲ್ಲಿಡ್ತೀವಿ, ಕಂಫರ್ಟಬಲ್ ಫೀಲ್ ಆಗಿ.
So these are all the minimal parameters that we are gonna examine for the patient whenever a patient visits our Sai Swasthya centers before the consultation gonna start. So now Sister Shilpa is capturing the body temperature of the patient. Now the height and weight measurement of the patient is going on. So now nurse has captured the height, weight, all the vital signs. She is going to save the record. Submit, click ಮಾಡಿ. Now that the vitals has been captured, we are proceeding for the doctor consultation. The doctor is seated in the remote location. Sorry? The BMI didn't auto-calculate. We'll check, madam. We'll proceed in the interest of time. Sorry, sir? Okay. So it has to be in the centimeters. Sure.
Can you just correct it to 1.62? Maybe the BMI will be calculated.
Oh, okay. And once all the vital capturing has happened, now we start with the teleconsultation. Can we have the video input of the screen? So there is a button called teleconsultation at the top. So the nurse just clicks on this teleconsultation and it redirects into another tab with the Google Meet. Now the doctor will start the consultation.
ಈಗ ನಾವು ನಮ್ಮ ಡಾಕ್ಟರ್ ಕನೆಕ್ಟ್ ಮಾಡ್ತೀವಿ. ನಿಮ್ಗೆ ಏನೇನು ಪ್ರಾಬ್ಲಮ್ಸ್ ಆಗ್ತಿದೆಯಲ್ಲ ಅವ್ರ ಹತ್ರ ಹೇಳಿ, ಅವರು ಟ್ಯಾಬ್ಲೆಟ್ಸ್ ಅಡ್ವೈಸ್ ಮಾಡ್ತಾರೆ. ಹಲೋ, ಗುಡ್ ಆಫ್ಟರ್ನೂನ್ ಮ್ಯಾಮ್.
ಗುಡ್ ಆಫ್ಟರ್ನೂನ್
ಮ್ಯಾಮ್, ಒಂದು ಪೇಷಂಟ್ ಇದ್ದಾರೆ, ಗೋಪಿನಾಥ್ ಅಂತ ಪೇಷಂಟ್ ನೇಮು.
ಓಕೆ.
ಫೀವರು ಮತ್ತು ಸುಸ್ತಾಗ್ತಿದೆ ಅಂತೆ ಸಿನ್ಸ್ 2 ಡೇಸಿಂದ ಮ್ಯಾಮ್ ಅವ್ರಿಗೆ. ಮತ್ತು ಪ್ರೀವಿಯಸ್ ಟ್ಯಾಬ್ಲೆಟ್ ತೊಗೊಂಡಿದ್ದಾರೆ.
ಏನೇನು ಕಂಪ್ಲೇಂಟ್?
ಫೀವರು ಮತ್ತು ಸುಸ್ತಾಗ್ತಿದೆ ಅಂತೆ ಮ್ಯಾಮ್.
ಜ್ವರ ಯಾವಾಗಿಂದ ಇರೋದು?
2 ಡೇಸಿಂದ ಇದೆ ಅಂತೆ ಮ್ಯಾಮ್.
3 ಡೇಸಿಂದ ಜ್ವರ ಇದೆಯಾ?
ಹಾಂ
ಜ್ವರ ಮತ್ತೆ ಸುಸ್ತ?
ಹಾಂ ಮ್ಯಾಮ್. ಮತ್ತು ಬಿ ಪಿ 190, 120 ಇದೆ ಮ್ಯಾಮ್.
ಹೌದಾ? ಬಿ ಪಿ
ಅದು
ಜಾಸ್ತಿ
ಬಿ ಪಿಗೆ ಟ್ಯಾಬ್ಲೆಟ್ಸ್ ಏನೂ ತೊಗೊಳ್ತಾ ಇಲ್ಲ. ಅವ್ರ ಫ್ಯಾಮ್ಲಿಯಲ್ಲಿ ಫಾದರ್ಗೆ ಮದರ್ಗೆ ಬಿ ಪಿ ಇದೆ ಅಂತ.
ಫ್ಯಾಮಿಲಿಯಲ್ಲಿ?
ಪೇರೆಂಟ್ಸ್ಗೆ ಬಿ ಪಿ ಮತ್ತು ಶುಗರ್ ಎರಡೂ ಇದೆ ಅಂತ ಮ್ಯಾಮ್.
ಹೌದಾ? ಹಂಗಿದ್ರು ಅವ್ರು
ಇವರು ಇದಕ್ಕೆ ಮುಂಚೆ ಚೆಕ್ ಮಾಡಿಸಿದ್ರಂತೆ, ಬಿ ಪಿ ಇದೆ ಅಂತ ಹೇಳಿದ್ರಂತೆ, ಬಟ್ ಇನ್ನೂ ಟ್ಯಾಬ್ಲೆಟ್ಸ್ ಅಡ್ವೈಸ್ ಮಾಡಿಲ್ಲ ಅಂತ ಮ್ಯಾಮ್ ಯಾರೂ.
ಹೌದಾ? ಹಾರ್ಟ್ ರೇಟ್
109 ಇದೆ ಮ್ಯಾಮ್.
So in the interest of time, right, there are so many other programs that have been lined up, queued up. So this is how the normal consultation happens, and the doctor goes through the screen and gives her input. Again, in the patient encounter screen that we saw in the last presentation, she'll order the investigations or the radiology investigations or the medications and close the consultation. So the point here is the Google Meet is integrated into our environment and just a click of a button. So all our Sai Swasthya Centers consultations where the doctor is not available is going to happen through the teleconsultation. So handing it over to the next team for the presentation. Thank you.
After the focus on telemedicine, we shift focus now to point-of-care diagnostic tools. All of us know one of the bigger challenges we see in primary healthcare, if you're not center-based, especially for outreach, is how do you conduct lab tests? How do you even do basic HB tests, sugar tests, right? So today we have a wonderful team. There are two organizations, two experts who are here with us to demonstrate some of these point-of-care tools. We will begin the session with Dr. Amol Gaikwad from the Anjani Mashelkar Foundation, which has been since 2011 committed to identifying healthcare innovations and spreading awareness about them. He shall be demonstrating 5 such point-of-care diagnostic devices covering key health parameters, including TB, COPD, asthma, BP, HRV, SpO2 temperature, heart rate, murmurs, oral and breast cancer screening, etc. Next demonstration will be from Ms. Tripti Nayak, founder Sanskrit Tech Solutions, who have a range of point-of-care solutions called Swayam Diagnostics. Today, they shall be demonstrating a customized backpack to enable outreach diagnostics, including BP, thyroid, HbA1c, etc. She shall be supported by her team member, Rugved. May I invite Dr. Amol and Ms. Tripti on stage.
Thank you, team. Hello. Yeah. Can you help with the presentation? So thank you, Soumya. Thank you, team. It's a privilege for me to be here and to show something which we are working on this. I really thank Srinivas sir and Subhojit for allowing me to be here. So I'm currently working with an Anjani Mashelkar Foundation. This foundation is working since 2011, which is being formed by Dr. Mashelkar, who is one of the renowned scientists of India. And how it is being formed, that he used to give some money to his mother when he used to go home. And when she passed away in month of November 2011, so while clearing of her stuff, they found a amount which is being given by the Dr. Mashelkar to her, and with a note that use this kind of money for the betterment of the people who don't get that kind of services, mainly in the healthcare. And with that kind of inspiration, he started the foundation. And the focus of foundation is truly on the inclusive innovation that can bring the access equality despite of the income disparity. How we identify the innovation? Because just one disclaimer, we are not any distributor to any medical devices or company. We want to scout for an innovation which can bring impact to the community. So how we scout for the innovation? So we see on this lens whether it's an affordable, whether it's an accessible. Accessible means that it can go to the any remotest part of country, can be used by any non-healthcare worker, and with a high quality. Right now, so like the CT MRI are the best innovation we say. So CT MRI, they are work with the physics, not with the chemistry. So can the physics be used in our point of care devices where we can go for a scale? Chemistry is not going to scale that fast the way physics can help us, and which is a universal. So any point of time, anywhere, it can give a uniform results. That is the key where we go for a scout for innovation. And from 2011, these are the innovator which Dr. Mashirkar has identified in different sector. It was no plan that we should work only on the healthcare only, but when we scout for innovation, we identified that yes, healthcare is the area where we should go and then work with. So these are the couple of innovation which I'm going to show you. How we identify also innovation is in what is the burden which we are mainly targeting. So it's in maternal child health, it's a tuberculosis, because yesterday also some of the people were saying that we are on the double-edged sword. One side we are the growing NCDs and still we are combating with the CDs. So considering what is the mortality and the disease burden of the condition, we identify the innovation in that particular kind of area. So you will see our innovations will be addressing some of these great challenges. And also on the affordability, and then we also don't have trained resources in the field. So the devices can be used by a non-trained paramedic or non-paramedic personnel in the field. And we also focus on the user experience. Say, just want to check, anybody in my sisters have undergone mammogram in her lifetime? Anybody? So is it a painful? So that's why we say we want to see that can we improve on the user experience? Can we go on the penless side? Can we go on the non-invasive side? But not compromising on the quality of the product. So everything cannot be on non-invasive side, but I will try to do whatever the possible non-invasive side. And also these are some additional challenges or gaps we also see, where is screening is an area which is very much spoke about, but very limited on the ground when it comes on the implementation side. Fragmented clinical data. Some data is on paper, some is some devices, something is on some cloud, but they don't speak with each other. So yesterday also one of the doctor from community medicine was explaining about the Aishman Arogya Mandir. So there are n number of software which don't speak with each other. So data is there, but if they don't speak with each other, you cannot come with a logical conclusion, or you cannot get good insight out of it. So then there's limited continuous monitoring. As we go to the non-communicable diseases, it's not only on detection. Screening will not help, but after the screening and detection, you need to monitor the condition. Because the primary goal of the screening or a non-communicable disease treatment is early detect and prevent the complications, because you cannot revert or you cannot treat completely the non-communicable disease. And then inefficient decision making because of the data don't speak with each other. So this is the care continuum. Generally, when anybody is working on a field for a particular kind of condition, you do the population stratification, you do the early detection, diagnosis, consultation, treatment, and then go to the monitoring. So from diagnosis to treatment, everything is done well in the hospitals. Where is lacking is the early detection and then the monitoring. So we also want to work in this field for the stratification to early detection and go for the monitoring. How we can help to the government, to the NGOs, to the Satya Swasthya team, where this part maybe we can strengthen and then can connect it to the middle gap where there is already lab and clinical hospital setup is there. So these are the three main pillars where we work, also we base ourselves, is in early detection with high quality innovations, the community first approach, and then intelligent decision as the data can combine and then speak each other. So these are some of the innovation which I want to speak with you. So what we have done, we have identified some of the innovation and we try to integrate this, because what happened right now also, I was speaking with the IT team here, the data has to enter manually. And there will be a lot of manual errors can happen. So if that data, whatever the device we are using, if directly connected with any EHR, the manual error can also reduce. So this is one small integration is being tried out, and then the journey is bit simple. So your clinic also, the patient is coming, you are doing the testing there, based on the test results, consultation happening, and consultation the person may ask the patient to go for another investigation or next level of treatment, or prescribe and then ask to do the monitoring. So this is the standard flow of a patient which we have envisaged in a primary care setting. These are the innovation which I want to demonstrate you here. So yesterday we had a very good session on the anemia, iron deficiency anemia. I just want to check to all my sisters here, how many of you have taken prophylactic iron folic acid? Prophylactic iron folic acid? No one. So this is the condition. This is as per the national program which intend to prevent the anemia. It has given a prophylactic test. All the females who are in the reproductive age group should take at least weekly once the iron folic acid supplement to prevent those things. And no one knows this. When you go on the field also, there is a behavior change from the diet, testing, and treatment. So there are, when you diagnose as an anemic, you need to take the treatment. But before that, you don't do your behavior change. Like yesterday also they were saying you cannot eat, you cannot drink tea or coffee 30 minutes before and after your meal. We may follow, we don't know. That's a behavior change. At the same time, preventive treatment we don't take, because it's a simple tablet you have to take it once in a week, which you don't take. So it is very difficult to control the anemia. Yes, what we can treat the anemia. And for the treat anemia, we need to detect the anemia. This is a device which we have recognized in last year. What happens, its issue is, yesterday there was 57% of female are anemic, but 70% of children are anemic. And iron is a bigger, what I'll say, important constituent for the development of the brain, myelins and everything. So intention is, can we screen the children? And with you go for a prick, it is very difficult for the children to screen. So with that thought, the innovator has come with a device which there is no prick required. It's an completely physics based, where there is a light is being passed between in the finger and then reflected light, and then the algorithm is being calculated and then it gives the value. It is ICMR tested. ICMR has given a go ahead that it's a publication also gone, and then there's a recommendation letter from the ICMR that you can use this in a community setting, because it's a screening device. It gives a value 0.5 to 1 from the normal range. This is a device I again like to thank Tata Trust on this part. When 2014, the innovator has come to Dr. Mashirkar that he has developed a 6-lead ECG. And Dr. Mashirkar said, I don't want a 6-lead ECG, I want a 12-lead ECG. And then he needs some amount, it's a big amount. And then Tata Trust graciously supported this. And now it comes with a 12-lead ECG. If you can see, this is a hardly less than a size of a credit card. It gives you 12-lead ECG, which is a medical grade. You don't need leads here, but the standard practice, we have that lead requirement. So he also comes with a lead requirement, and it is being used in Assam right now. This is another device which I personally like. It's an multi-para monitor kind of thing device. It's a single device which can, in 30 seconds, can take your blood pressure, temperature, SpO2, heart rate, breathing rate, The good part is heart rate variability because it takes a single lead ECG also. So second, the next is as an NCD we are speaking, we are mainly focusing on diabetes, hypertension, but there is limited focus on the respiratory conditions. And COPD is also becoming. So if you see the global mortality, COPD comes to the next to the cardiac mortality. So it's a bigger problem. And then there is no point of care devices apart from the spirometry, which also comes in different forms, to detect at least this is a person who has risk need to go for further testing. So this is a Shwasa innovation being developed in the Indian Institute of Science by one scientist. What he has done, he has identified cough as a biomarker. And with the help of cough, he has a huge data bank on this. And then he says, based on the cough, whether the person has a risk of COPD, whether it's an risk of TB and asthma in single cough. So you'll get a screening for the 3 lung conditions. He's also working on the pneumonia. The limitation of this is only applicable to the people who are age more than 18. For children, he's yet to come with some models. This is iBreast as a patient experience also I was speaking with you. This is the device is a handheld device. I'm sure all of you know that breast cancer is the leading cancer in India. The screening, as per the government guideline, every female whose age is 30 years and above has to undergo for oral breast and cervical cancer examination. Breast cancer and cervical cancer is a problem. Oral can be possible because of the privacy issue. And the Niramai or what are the thermal devices are available, what patient has to undress for a certain period of time, and then the body temperature and the environmental temperature has to match. So at least 5 to 10 minutes, female has to undress and then wait. So it becomes a difficult situation. So this device comes with a capacitive sensors. More than 500 sensors are there, and then it measures the elasticity of the breast tissue. And once there is a change in the elasticity, becomes a fibrous tissue, so that the lump is being detected. This is an FDA approved device, so a lot of tests being done, and government of Goa has done 1 lakh of screening with this device with UVCAN Foundation. This is another device which is very, I prefer to have in any clinic where there is a huge tobacco consumption in that, because oral cancer is also one of the leading cases. That's why government of India came with the program. This device doesn't only tell you about the precancerous lesion, but also tells you whether you need to go for a biopsy or not. So it will give you a classification. Okay, this is at risk, but you can wait, follow up for the patient. And when there is I'll say a precancerous lesion is going to near to cancer, it says no, you have to go for biopsy immediately. So that kind of information can be get for this. So this is the person, some of you may know about the Trinetra. It's an retinal scan device. The same founder has come with Indian-made dialysis machine. But I'm more interested with this, the point of care which he came for the chronic kidney disease. So it's a strip-based, there are a lot of strip-based companies also came, and it creatinine albumin ratio it gives you. So what the beauty is, all the diabetic and hypertensive patient are going to land up into kidney failure. Because all the NCDs have either heart complications or renal complications or retinal complications, right? So the kidney is leading next to heart goes to the kidney. So kidney is, we need to see every 6 monthly those patient, my patient coming to my clinic for at least 6 months, I should test their kidneys are good or not. And every time I could not ask them to go and do the LFT or KFT. So this is the test which we can use it in our clinic and see whether the person is going to the CKD or not. Some of the innovation which are in pipeline, I just want to show to you. These are the small, hardly 5 centimeter kind of device. It is in the IIT Roorkee. You just need to blow for 2 minutes and you will get the information that whether you are at risk for or you are suspected for the breast cancer, oral cancer or lung cancer. It is in trial phase. This is the Hill, which is a device. It works with the PPP sensors. You need to put your 2 fingers here and you get 28 parameters, including the HbA1c and all that things. It is still in the testing phase. It will take at least 6 months to come with a good value. And this is one device is where any person who fever, we can differentiate whether the fever is due to malaria or due to the dengue or chikungunya. And there are many more innovations are going to come. So as a foundation, we like to see all the innovations and then see where we can deploy into the different community. So I'd like to have one volunteer, if Dr. Sriram sir can come, and then I'll show you how it works, the devices which I'm showing to you. Yeah, thank you. Chair, I can get chair. One chair. No, I'm testing him for the anemia, as HB. So the camera can come so that everybody can see. Yeah. This is the Health 360 device, which comes with the multiple parameter recording. Patient should be rested with the back, and then his legs also rested completely. So patient is rested well. There is an application which tells whether you need to what test you have to do it. But and the device also you can do testing in device without the application, and with application also you can do the device. Right now I'm using the application. So it is connecting with the device. How it is connected. So can you show the device here? No, so the camera. And it also comes with, the only thing is one request to the patient, don't move, because all these things, when the patient moves, the vibration changes, and the patient should not speak. Once it is done, it will give you a value. So once it is done, it will give you a value. What is the blood pressure? 120/78. It's blood sugar. So right now, this device is also we are using in the blood sugar estimation. So non-invasive blood sugar estimation, but we don't want to give a particular figure. It will be in the range. So like between 130 to 140 kind of thing, that we will figure it out. Also the temperature is also coming with this, SpO2, heart rate variability, breathing rate, and heart rate. So these are the parameters you can see in the device also, and this information is also fetched into your mobile app. A PDF report can be generated, or this can be transferred to any EMR or EHR. So this is the 30 seconds device which we give you all your vitals with you. So yes. So what I request you to, we'll finish this, all the demo, and then we'll take questions. Will it be okay, sir? Thanks. Next, I'm asking him to do the lung testing. So this is an application. This is a Shwasa application. I'm just registering the patient. Once you have integrated with your EHR, no need to have multiple registration. Once you register the patient, it tells you whether you want to use this phone or patient phone for the testing. What you have to do is you have to keep it in 90 degree to your mouth, 4 to 6 inches away, and you have to cough. So now I'm requesting sir to cough. You hold it in 90 degrees. Sir. It also asks you about what are the symptoms here. I'm just skipping the symptoms part. And, you have to cough 4 times in 10 seconds. So that will be good. I'm just starting. So whatever the cough they have done, now the system is uploading cough. If there is an inadequate cough, it also says ki you do it, repeat the cough. And say it will take at least 60 seconds to do the, now it's verifying the cough characteristics. And then it says, ki okay, now it is not enough cough, you need to cough more. So I'll just show you yesterday's his reading when we have done this testing to him. I don't want him to cough multiple times. Can you come to this? Can you see on the screen? So this is report is coming where you can see the COPD risk, the asthma risk, and the TB risk. It also comes. It comes also on PDF report where the PDF can come. Okay, so PDF also come. Right now, Dr. Reddy and some companies are working with them. So they are working on what part? Because the beauty is this report also gives you cough count where you have a dry cough and wet cough. And based on this, you can prescribe them whether you need a dry formulation or a wet formulation. Also, it also has a lung health index. Lung health index is high means it's a bad thing. And with your treatment, if the lung health index is coming down, that means your treatment is working. So you no need to ask the patient to go for multiple times to do the X-rays. So this algorithm is being published in the Nature. It is being tested with the ICM, CMC Vellore. Both have then given a go ahead kind of thing. And also right now, they're working with the ICMR to do the final testing. This company or the firm has been also being part of the Tata Trust fund, India Health Fund. So they also supported them. So this is the two things is, and then so this is a small ECG which I like to say. It is you have. Where you have to touch on the chest leads. There is a protocol and it gives you results. So now it is very difficult for a health worker to tell them. So an individual patient can take it and then do it his own ECG in home. So what happened, then this machine has been devised like that I can connect to electrode. All our standard electrode, all ECG electrode can be connected to here and we can do the ECG with this device also. The next is, I'm sure a lot of you people are using HD step. So it is a stethoscope which can measure record the heart sounds and do the murmur. So this is also new innovation. I'll say not new innovation, but a kind of innovation which is going plus. So they are also measuring the lung sounds and now working with an ARI. So they are also developing a protocol for because ARI is a bigger cause for the childhood mortality. So this will be not only helpful for the cardiac condition, all the valvular heart condition, and also for the respiratory condition for the children mainly. A couple of innovations which I like to show you on the cancer side. So this is the iBreast, which is a completely handheld device. It will connect to any phone, and there is a software device, and you need to just touch on the breast. It will tell you whether there is a lump or not. You need to move accordingly. That parameter will tell you how to move it, and no need to completely undress. The breast which is being examined, that has to undress, and that part only undress, and then we can complete the examination on the both sides. This is a FDA approved device, and in Government of Maharashtra, all the medical colleges has this device. So this is a simple oral scan. It's oral probe, which can be connected with your system, and you can take picture on this. There is a software on your system can be taken, and that picture will tell you that once you apply the algorithm onto this and software is playing, you can tell that whether the person needs a biopsy or not, whether this is pre-malignant or not also. So these are the, I'm sure because our work is mainly on the primary side, so all times cancer may not be possible, but that you need to see whether we are to going on for the cancer side or not. That's the intention where we want to show this. Last part, I just want to check on this hemoglobin. Yeah. So for hemoglobin, this is a kind of application for this. This is a device which we need to on. So here what happens, this is a sensor, so you cannot place directly the finger on the sensor. What I request to the patient to take the wrist support, and left hand ring finger is the ideal finger for you. The issue is if there is some mehendi or some discoloration, it will not give you the better result. So that's a disclaimer. And also the temperature at the terminals at the ring should be less than should not be less than 15 degrees. So what we generally do, we just rub the finger so that the blood flow will be good. And also see there should not be any sweat. And then we request them to place it properly. I'm just adding the patient right now. Now it's connected, but before connecting, I'm just checking whether the pressure is enough or not. Now pressure is enough, and testing is started. So it takes 60 seconds to give you a result, but it is helpful for the children more than 3 years of age. We have done 10,000 of children screening in Pune with an organization, Swarup Vardhini. They mainly work in the school, so it was good for us. Now we are also working with them with the stethoscope, so that can we identify some of the people, patient with the congenital heart disease. Now it comes as a result. So 13.9 is the value which sir has. So it gives you 0.5 to 1 variation, but it's a good tool for you to monitor the patient, whether it's anemic, not anemic, what are the medicine you are giving, whether it's working or not working. So these are the innovations which I like to show you right now. So if you have any questions, then I'm happy to answer that. So if you have any questions. Thank you, sir. Thank you very much.
Thank you. In fact, when they tested my lungs, this thing is I have allergic airways, and I have seasonal allergy, and I'm forced to use Duolin bronchodilator once in a while, and severe nasal allergy and also bronchial allergy. So budesonide I use both for nasal as well as this thing, especially rainy season and winter, and this tablet. We were debating yesterday. So one thing is adding to whatever Amol has described at length, The way that we speak of diagnosis-related drugs and all that, diagnosis-related tests, even technology has to be diagnosis-related. Just because you have to technology and you want to push the boundaries, never try to increase the cost of healthcare, just a sake of doing it. Of course, we really need to look for advancements and innovations, but focus on the priority areas, it bases on the disease burden. Rest of the things would come later, as simple as that. I think you focus on the disease burden and then tune in technology with that. They have to be in sync, you can't be away. And more than anything else, then the interpretation part of it. And once you do these things in screening and detection, please don't let go the patient. You need to provide the treatment. Do you have the backup? That you have to make sure. If you cannot connect the patient to specialty care, you are not doing the right job. If I tell the people you have a chance of cancer and you have cancer, he is not going to die of cancer, he is going to die of fear of cancer. The whole family will go to dogs. For God's sake, that's where I think with Sadhguruji yesterday he went on insisting the vision has to be compassionate care. All of us were good doctors and we have commitment. But compassion is something that should come from here. And even compassion has to be evidence-based, maybe. Thank you.
So I'll say they are affordable as per the current rates. So I just want to tell you the rate. This is this company. See, company offers you at 14 rupees per test. Any device, I'm sure, is more than 20 rupees per test. I'm sure they don't charge for ECG if you get that device out. The MRP of device is way high, but that can give it to us 25 to 30,000. But we can also negotiate on this. We are also what we are doing. We are integrating everything. So we are also negotiating with these companies. We want to make it on different models. So right now they are saying a capex model also. But what we are also trying to do is, can we do per patient model also? Can we come down to the cost also? So that's a different discussion which we are also doing with this company, because the vision which you have. So I was moving from one company or one organization to other organization that I want to set up some wellness centers. So that's why I'm moving from one. And then this organization is also want to do some centers as a Engineering Master Foundation. So our vision is to, okay, can we do this integration and give, so there is one sector, which is an NGO sector and private sector, government sector. In private sector, hospital is the leading thing. We are also targeting the general practitioner, which are BMS, BHMS, or some other Ayush doctors, which not have access to this kind of innovation. So I'm targeting this kind of clinics where this can be helpful for them, and also going a command center support. Because see what happens, any clinic, patient comes, medicine given, and then cash collected, that's it. Very few maintain the relationship. So can we develop a kind of command center for this kind of people? That also we are exploring. So where I can see synergy in the vision which Satya Seva has, and also what we want to do it. So somewhere we also want to come together and see, we can speak with this kind of people that, okay, there is 10 lakh of screening going to happen with Satya Seva, and then maybe another 5,000 or more, because our scale is small. So we are also doing some small level. So can they give us a better option? And I'm also requesting the IT team here also, how we can be API configurable, because if you speak with each people, they will say that there is a cost of integration. So what we are doing is we are also requesting some donation from the different organizations to integrate into one thing, so that it can be fleshed to any EMR or any EHR. And it's not only this 5 can, we are also looking for good analyzers, because in clinic you don't have some the blood tests also, then it will not help. Or if you have a blood test, it will help you to give a better treatment. So what are the good analyzers are coming in the market? Can we integrate with this also? We want to go on a patient experience also, but also on the accuracy of the care. Thank you. Sorry, ma'am. So if you see the cost of the device is 4.5 lakh is the cost of that device, 0.5 lakhs. But if you go on a per patient model, they will come to around 250 rupees per patient kind of thing. So I just want, what we are doing with the clinics here, we are clubbing the 5 clinics and asking them to take one device so that you can rotate, because cancer is not day-to-day screening. You can identify one day and keep all these devices to your clinic and then do the screening, then next day for next clinic. So the cost of device also be shared, and then you can get what you want out of it.
That was truly a very, very informative and interesting session. I would request the SWAYAM diagnostic team to come up next and demonstrate the backpack.
Hello. Okay, good morning everyone. Om Sai. So first of all, thank you everyone for giving us this opportunity. Can you please, excuse me. Okay, myself Trupti, I am a co-founder of SMSGHM Smart Solutions. So what SMSGHM Smart Solutions do, we are into healthcare diagnostic system. So we have developed healthcare ecosystem. So what is healthcare ecosystem? So that is primary diagnostics, then data analytics. So I'll show this is, we have various variants in diagnostics thing. So first is health kiosk. Where did it change? Then we have a backpack model and van. Apart from that, we have telemedicine and doctor-patients app admit dashboard. So today we are going to demonstrate one of our product here.
So I would like to ask somebody for volunteer, as a volunteer to test. Anyone? Ma'am, if you could join us. Ma'am, if you could join us. We just will do like one blood test, that is it. Yes, sure. So this is our healthcare product. We have integrated all the non-invasive tests that we have seen in this seminar. So blood pressure, SpO2, be that ECG, everything is there. We also have non-invasive parameters integrated, that is HB, that lipid, and then glucose. So the idea is that you don't just test and then insert it manually. Everything is synced to our complete product. You can test on the same product, the results will be shared directly at the same time, and then you can connect to a doctor via video consultations. The doctor will get the results live, and then he can diagnose you based on that results. So if you can get the screen on there. So if you're a first-time user on a SWAYAM health ecosystem, then you have to go through a registration process. So this is a basic registration process that you have to go through on any platform. So you can, you have to insert your phone number, your name, height, weight, all those parameters. You can also capture your profile photos and biometric. So this is biometric locked. All your data will be locked via biometric. Once a patient is registered, then they can log in via their parameters. So I will just log in by my parameters. So this is all the functionalities that we offer. You can do all the tests which are on the left hand side. Yeah. So on the left hand side, all the tests are there, and on the right hand side, you can consult a doctor. You can view all the reports that you have done. All the previous reports will be synced to a cloud. You can view those reports. We have 100 different plus parameters that we have integrated. You can do non-invasive tests like BMI, blood pressure, SpO2, all those things you can do. And then we have our blood parameters. So I will demonstrate how the blood parameters will work. For that, I will do a hemoglobin test.
Actually, we have different variants. So we have integrated up to 150 health parameters. And this is a backpack model, so it is very customized and portable version. So it has up to 5-6 days, like health basic vitals, plus hemoglobin, lipid, and glucose.
What is the validation for lipids?
It is FDA approved devices. All devices are medically approved. All the tests which we have integrated are finger pricking method, so you don't need a big amount of blood here.
So now the device is communicating with our system, and once I insert the test strip, within 5 seconds the result will be directly shared to the device. So now
Yeah. Yes, sir. Yes, sir. 95%, 90 to 95%.
Yeah.
Pardon? Yes, sir. I'm not that technically.
Hello. So I'll tell you,
medically
sir.
approved.
I'll give answer of this. Sorry, I'm taking.
Yeah,
So
no
in
problem.
this, what generally they do as an CDSO, they compare the result with a standard lab, any NABH, NABL accredited lab. They see number of tests. They need to get the what number of sample. Ideally, they should go for 150 plus samples,
Yes,
and then
sir.
match
We
with.
have done more than
So that they have to match
10,000.
with the what is the value coming into the NABL lab, and then they plot the aggregation. So the aggregation has to be more than 95%.
So,
Yeah.
So
Yeah.
adding to his point, we have done all this
see,
tests.
we are working since last 7 years, so we have done almost 10,000 up samples, validation samples with different labs.
No, I don't doubt the competency. I just want to bring the attention to everyone here. We had the opportunity to test around 12 different glucometers in our laboratory. And the laboratories, this was actually, we borrowed it from Roche. It's a kind of they invest and then over a period of time we take over. This is for a multi-specialty hospital. I was the vice president. And tell you, out of 12, only 2 glucometers they stood the test. Even Johnson failed. The country manager came running. I said, it is 6 out of 10. Wrong. And there are certain issues, actually. Another thing I wanted to make point out is sensitivity tests like uric acid and all that. When you do it, it has to be in the laboratory. I am not commenting on point of care. You should be using a deionized water to wash the cuvettes. We had a real problem. The thoracic surgeon went on complaining. I said, I'm getting these results wrong. He was upset. We went on digging into the bottom of it. Finally, I realized that somewhere on the net I found Roche spoke about deionizers. Then I inquired and I spoke to various hospitals in Hyderabad, including KIMS, Apollo and other things, and Dr. Bhaskar Rao helped me out. He gave the clarification. If you use deionized water, they sell 5 liters of bottle. I purchased from Hyderabad, started using it. Thank God we were able to get good results. There are certain hidden things that medical profession, we don't pay attention. That's the reason I think all of us should be conversant with the technology, challenge the technology. Same thing goes with the defibrillator monitors. How many of us we pay attention to what kind of energy and what is the maximum type of thing, and we know the protocols. That's the reason. Otherwise, I never wanted to make another point.
No, totally agreed. And that is why we have a complete process to select what kind of devices we integrate. We have a stringent, we test multiple devices and then we choose a particular device. Other than that, we are not trying to replace a laboratory or something. We want to work together with a laboratory to provide better results and better reach to the healthcare solutions.
No, intentions are good. And one question related to the equipment, for leaving the rest of it. How is it, ma'am? You have included a good number of tests in one. Is it modular? If something is not working, rest of the things also will fail? Or
yeah, definitely. It is modular, so
it is modular.
Yeah.
Thank you.
Yeah. Yeah. No, so modular means if something breaks, one of the instrument is not working for whatever reason it might be, then other instruments will not be hurt because of that. So you can continue testing on those parameters. Others will work, yeah. So once the result is there, can you just get the screen back? Again, so this is all automated, all synced to the device itself, no manual interventions. Once the results are there, you can finish and then this will be all, the results will be generated, it will be synced to the cloud. You can also get a printout. You can also get a printout of this report. So this is, I did hemoglobin right now. Yeah. So you can do like 5 tests at a single prick. That is not an issue. Once the test is done, lipid profile, actually these are all strip based. So we have glucose and HB.
Device is there, but strips is not there. Yeah. That's why. Okay. If you know your hemoglobin, sir, you can do your test, or sugar.
So once the test is done, everything will be synced to the cloud. Now we also have our own user app, if you can see. On the user app also now the report is synced. So now it was my account that we did his test on. So once I go on to the report section, this is the same report. This is the same report that we had on this device. So everything is cloud sync instantaneously. Not just that, you can at the same time share this with the doctors via video consultations. So the doctors can view all your past medical records. If you want to share it with the doctors, he can view all those on live video consultations. We have integrated stethoscopes and everything. So if the doctor needs to, he can also listen to the heartbeats live on the video call. Now that the user has done its test and everything, on the organization side, if you have multiple of these devices deployed, then you can monitor those devices back from your offices, back from your homes, however. We have those backend panels also. This is our master panel. This is our master panel from where you can check all those. So you can see how many users you have registered, how many tests you have performed, how many devices you have in place currently on ground. You can monitor everything. You can also do analysis. So disease analysis, like if you have done certain number of glucose tests, so it will segregate based on how many users you have currently who are diabetic, pre-diabetic, or they have normal ranges. So all those classifications and segregations will also be there, and you can customize this based on your requirement. So if you require certain parameter, and if you don't require certain parameter, all those could be filtered out from here. Diagnosis. So this is diagnosis analysis. So all the screenings that you do on our tests, how much does it cost?
Actually, there are different variants. So if you are looking for home purpose, so this is actually. Yeah, so after we finish this demo, we can discuss on the cost and everything.
Yeah. This is client panel here. So you will get access to all the registered users. You can see what all users were registered. You can see what all kiosks, what all devices are currently active and on ground. So if, let's just say, one of your device which is on ground is currently not active, and you want to fetch what kind of device it is, what is happening, you can do all that from this particular panel. You can also export all these records of users per device or in bulk from our panel. So all this diagnosis or all this data collection part for your screening purpose is on this single panel. You don't have to go anywhere else. You don't have to contact us. It is all in your hands, and it can be done instantaneously. Other than that, for doctors, for our video consultation platform, we also have our doctor app. So if a particular doctor wants to connect with their patients, we have a web-based platform as well as a mobile-based platform. So we are on iOS and Android both. You can connect with your patients from the app or the web panel. Once a user posts a request on the panel, it will show up. You can join, and then you can consult the doctor, consult the patient. You can give prescriptions and all the things that are required. And those will also be cloud synced. Yeah.
Okay. So we are done here. So if anyone have any question, later on we can take. Yes, ma'am. Fasting is necessary.
Okay, thank you.
So thank you everyone for listening us.
Thank you, everybody. Thank you.
Does anybody else have any questions for Dr. Amol? Any remarks on if you think these would be useful in the work that you do? Do any teams do outreach apart from just care-based, center-based care? Any teams currently doing outreach?
Yes, we are doing outreach. We are going to the villages.
Which region are you from, ma'am?
I'm from West Bengal.
West Bengal.
Okay, so West Bengal.
Which of these that you saw today you think is relevant to the work that you do?
All the tools are relevant to our work, but we have to be techno-savvy, but we have to learn more about the technical problems.
So currently, where do you refer the patients for lab tests?
We just doctors write on the prescription.
We're
and
not
the
really monitoring whether they're doing it or not.
Yeah, we are doing the BP, RPS, hemoglobin. These three things we are doing. For the rest of the investigations, patients are doing
Need to do
themselves.
it.
Yeah.
So that way, this will ensure that
Yeah, we get
you
all.
are immediately
we are
doing
immediately
it.
get
Got it. Thank you so much. Like we discussed in the morning, the third pillar of Sai Swasthya Rally is timely referral. And a lot of questions that are asked is, suppose we find somebody to refer, how do we do that? What is the process? Which specialities are available in this ecosystem of Shri Madhusudan Sai's healthcare mission? So today we will have senior faculty members from the medical college who will share which cases and how Sai Swasthya and Sai Arogya hospitals can refer the patients. May I invite on stage Dr. Hiremat, World Bank and Academic CTVS, Senior Consultant and Chief Cardiac Surgeon, Pediatric Thoracic and Vascular Surgeries. The second is Dr. Anand Kumar Agarwal, Senior Surgeon and HOD CTVS, Dr. Kulbhushan Bali, Deputy Medical Superintendent and Assistant Professor, Otorhinolaryngology, Dr. Sri Harsha, Assistant Professor, General Surgery. So we'd like you to, if you could start with one by one in terms of the departments and we can give you the what the scope of referrals could be to the respective department and others related for the medical college.
Yes, hi Ram to all of you. I am Dr. Anand Agarwal, cardiac surgeon working here from last 1.5 years. So I represent Department of Cardiothoracic Surgery and my cardiology colleague Dr. Naveen is not there. So in brief, we have started the Department of Cardiology here 2.5 years ago. We have both adult cardiology and pediatric cardiology. So we are able to cater to acute coronary syndromes. What I mean to say is patients who come with any heart attack, we are admitting them and stabilizing them and taking up for angiogram. These patients might need medical management or angioplasty or what we call as stents or bypass surgery. So all these facility is there with us. And also in adult cardiology, we are doing pacemakers. That is the patients who have got different type of heart blocks. And in pediatric cardiology, we are doing diagnostic cath, that is small children when they come for pediatric cardiac surgery, whether they are suitable for cardiac surgery or not, we do a cath study. So that facility we have. And pediatric cath intervention, that is small holes in the heart, whether we can close with just device. That is on the cardiology front. On cardiac surgery, we are doing all spectrum of adult cardiac surgery, like bypass surgery or valvular surgery and all intracardiac masses and all. And in pediatric cardiac surgery, also we are doing all spectrum. Apart from our in-house surgeons, we are tied up with one Healing Little Heart Foundation of UK. They have done six camps till now. In each camp, around 10 to 40 surgeries are done. During Sadhguru's birthday last year, 45 surgery and interventions were done. So as a whole, Department of Cardiology and Cardiac Surgery, we are able to cater to most of the normal conditions. So regarding referral base, I know around 27 Sai Swasthya are there. I work very closely with Brother Kalyan from Hyderabad and Shubhojit from Kolkata, and even in Telangana 2 or 3 centers. So I'm sure there is, I don't think any formal referral portal is there, and I think Shubhojit, we need to establish that, so that any of the centers, if they have a positive case, we should have a proper portal. I think we should all work towards that. Yeah. So the idea will be for the Sai Swasthya, if at all you have any cases for cardiac, and my colleagues will be speaking about their specialty, there should be a seamless this thing. And on the other side, we also do preventive work. I think the time is not enough. At some other portal, maybe online, I can connect to all the Sai Swastha. Thank you very much, Sairam.
Sairam to one and all. So I am Dr. Sri Harsha. So I work in the Department of General Surgery as a consultant and assistant professor. So my training was from Postgraduate Institute of Medical Education and Research, Chandigarh. So I have been working in our hospital here, the Sri Madhusudan Sai Institute of Medical Science and Research, for more than 3 years now. So the Department of General Surgery here, we cater to almost all laparoscopic surgeries that the patient requires. For example, laparoscopic hernia repairs, laparoscopic gallbladder surgery, appendix surgery, fundoplications. And coming towards the cancer surgeries, our department, we cater to breast cancer treatment, thyroid cancer treatment, and gastrointestinal and hepatobiliary surgeries as well. So if we look at gastrointestinal, probably we have done more than 50 stomach cancers, colon cancers, and rectal cancer surgery here, and probably more than 250 breast cancer surgeries, and close to 100 thyroid cancer surgeries as well. So probably since we were just discussing about the breast cancer screening program and all, if the Sai Swasthya Wellness Centers, if you are able to pick up any breast lumps or suspicious for malignancies, and if it is diagnosed, our department is here. Definitely we can work out for treating the diseased, the diagnosed ones. And if we apart from all these surgeries, we do have DNB students training programs, and we have 4 students as well in the department. And we do conduct a lot of CMEs and academic activities as well, and we also support our fellow faculty members for their training as well. And like Anand sir was telling, it is a need of the hour to have a streamlined process where patients from elsewhere can have a straight route for surgical treatment in our department here. So that's it from general surgery. If anyone has any questions to ask, maybe I will take it after Balit sir finishes. Thank you.
Sairam to all my brothers and sisters. I am Dr. Kulbhushan Bali, and I am head of the ENT as well as head and neck surgery department of Sri Madhusudan Sai Institute of Medical Sciences Research, and I am assistant medical superintendent also of the hospital. I was outside India working for 3 decades outside India. In 2018, on command of our Sadguru, I came and left the worldly world and working already here in our institute. And about the ENT and head and neck surgery department, coming to the outpatient clinics. So we have got approximately 100 outpatient clinic per day. We are catering the people from not only from our state, from other states, as well as from the other parts of the world also. We have got 6 faculty members in our department, and we are having all types of equipments which you can think of in diagnostic as well as operative surgery. We deal with the small children, newborn children, as well as the adults up to the age of 90 years. We have got a program in our department of newborn hearing screening also. The moment the child is born, we can test his or her hearing by doing the newborn hearing screening. And about the other diagnostic tests also, we have got all types of endoscopic diagnostic tests of ear, nose, throat, and head and neck surgery. We have got all types of scopes and towers, and we have got full audiometric department also. Even we have got testing equipments for the brain stem evoke response audiometry, along with the other audiometric tests and play audiometry and the pure tone audiometry. And assisting to us is the radiology department, which is having CT scan and MRI, which we can do and predict any other ailments in the head and neck and ears. Coming to the operative surgery, we do all types of operative ear, nose, throat, and head and neck surgery, and base of skull surgery also we are doing. And you can compare our department with any department of the world in the field of ENT and neck surgery. Apart from doing the routine surgeries of ear, nose and throat, head and neck surgery, and cancer surgery, we are doing the specialized surgeries also of the base of skull. Base of skull surgery also we are doing, and that too with the help of the scopes. And the scopes we are doing. And we are doing the middle ear as well as the inner ear surgery also if the demand is there. And we are getting referrals not only from the Karnataka, we are getting referrals from the other states as well as from the outside also. We have already started treating the international patients also. And I'm open to any questions you want to ask about my department as well as from the hospital.
So since I have the mic, I'm taking the advantage of asking the first set of questions. Since they've all seen the hospital, I actually wanted to request for an overall summary. I have 4 aspects to it. Sorry. What are the OPD timings and processes if patients want to come and register themselves across departments? What are all the departments that come under OPD? What are all the departments that come under IPD? And what are all the diagnostic facilities available?
You want me to answer that? Okay. First question was the OPD timings. Our OPD starts at 8:30 in the morning and finishes by 4 p.m. These are our OPD timings. And very soon we are going to start another OPD block outside the hospital where the patients will be screened and only the demanding patients will be sent inside our institute. Our IPD patients, anytime they can come, and the emergency is also open round the clock, and 24/7 we are providing the facility for the emergency doctors, for the emergency patients. Then second question was about the departments which we are having OPDs. So we cater almost all the departments in the OPD, and we have got IPD patients also for almost all the departments. The departments which we are lacking is still in our hospital is the primarily we don't have the neurosurgery department at present in our institute.
The question is, do you have renal? Renal.
Yes, actually the nephrology specialist is coming on regular basis. She is coming every week on a fixed day. We do have, but not on regular basis.
Got it. And what are the overall diagnostic facilities, suppose?
And I forgot, you asked how many the OPD numbers in. Our OPD numbers per day crossing 1,400 patients per day. It's really difficult to cater this much big number, but we are still managing and trying our level best to give the best of the best services to our patients. Tell me again, sir. Yes. 1,400 patients includes the old patients as well as the new patients, and includes the referrals also. Yes. And the conversion rate from the IPD to inside is approximately 30%.
Hello, sir. Yeah, Saidam, sir.
For? Depends on the specialty also, depends on the patient condition. If it needs urgent attention, we attend urgently. Otherwise, they can take an appointment. We have got an appointment service also. There's a phone number, you can take an appointment also. If the patient comes to the OPD, we never send any patients back.
It's about general surgery.
Neurosurgeon, I said we don't have the facility of neuro. We don't have, at present we don't, and I am dealing with all the neurosurgery patients, and at present we don't have the neurosurgeon.
Yes, sir, it's about general surgery.
Yes.
Any pancreatic surgery or any stunt you are doing here?
Very apt question that you asked. Thank you for asking me this question. So ours is the only hospital about 60-kilometer radius to have conducted pancreatic surgeries in our hospital. And I'm very proud to say that our department, we have performed more than 38 pancreaticojejunostomy, which is phrase procedure done for chronic calcific pancreatitis. no other institution in 70-kilometer radius has done this surgery. And I'm also proud to say that our department, we have performed 8 Whipple's procedure, which is the top-notch surgery for pancreas, and that too one by laparoscopy. And this is not at all done in more than 15 centers in India.
Thank you. Thank you so much, sir.
I just wanted to add in Dr. Harsha's comments. In Bangalore, they are doing all of the Bangalore, I'm telling, the urban Bangalore, the phrase and the Whipple surgeries done in 1 year, not more than 10. And they have done 33. And that also, nobody boasts here. And 33 surgeries, Whipples and phrase surgery, which are the top end surgeries in the pancreatic jejunostomy. If I'm correct, then yes.
Absolutely right. And with God's grace, all the patients have been successfully discharged with 0 mortality.
One more feather in the cap of surgery department here. Recently, they did one diaphragmatic hernia, where the whole diaphragm had gone to the left lung, and left lung was totally collapsed. And that too, they did it laparoscopically. And in the world, nobody has done this type of surgery up till now. And recently, it was done.
Any other questions, particularly जो आपने already field में देखे हैं cases या आप frequently आप देखते हैं, अगर इसके बारे में कुछ questions है तो please पूछिएगा.
One thing I just want to say that it's an open platform and it's a two-way conversation. And if you are feeling difficulty in speaking English, you can speak in any languages. We can answer, we'll try to answer in your own language. So please do not hesitate. It's a good platform to ask anything in any language.
AP, Telangana, Karnataka teams, Tamil Nadu teams, మీకు ఏమైనా questions ఉన్నాయా?
Punjabi, Arabic, French also we can speak in.
Punjabi, Arabic, we'll figure out a translator. తెలుగులో అడగండి. Okay, Telugu, Tamil, Kannada. If specific reports, let's discuss after the discussion.
Let me answer one more question that sir was actually he asked. What about the waiting period? So I think every department will make sure that the priority goes to emergency cases first, malignancies next, and elective surgeries last. So if in case we get any referral for emergency, it will be addressed to within 12 to 24 hours. And if any malignancies are referred, any cancer, that which can be operated at our hospital here, probably we will prioritize it to be operated within a week's time after investigating, staging the disease and everything. And if it is a completely elective procedure, say for example, a gallbladder removal or say a hernia repair, which is elective, it may take a week, more than 2 weeks time, since we have a lot of waiting period in our hospital, which usually is around 10 to 15 days for any elective procedure.
Sir, actually we are providing all the facilities here. Before I answer your question, 2 things I forgot to mention. One is about the ENT and head neck surgery, that we are doing cochlear implants also. Regularly we are doing cochlear implants in our hospital, which is a very high-end surgery, and it's very costly surgery. And before, when we started doing cochlear implant, the cochlear implant cost itself was approximately 50 to 60 lakhs. Now the cost has come down to approximately 15 lakh rupees, and with the support of the government and with some other NGOs, we are doing cochlear implants, and mainly we are doing for the Karnataka patients, because this cochlear implant program is divided into states. So ABRK patients we are getting state-wise. So and if the PMJ patients are there, we can operate, but again the problem comes, and sometimes the NGOs, they give us some implants, and regularly we are doing cochlear implants in right from the age of 6 months up to the age of 60 years. We are doing cochlear implants also in our hospital. And we have got all the facilities about the AVT, the audiovascular training after the implant and the speech therapy. So our departments are fully equipped with that. This is one thing. And second thing which I forgot, that we do have a radiology and radiodiagnosis department, but we do not have the radiotherapy department. So after doing the oncological surgeries, we have to refer the patient, and that facility is going to be there in our new hospital. As sir asked this question, and our new hospital will have the neurosurgery department, and this radio oncology department will be separate. The other new thing which we are going to start in our new hospital will be the medical tourism. So we'll be having patients from all over the globe, and they will be coming here, and one floor will be totally dedicated to the medical tourism patients.
Hello, sir. Any protocol for the pancreatic?
Sir, I wanted some questions from this side also. Our Nari Shakti.
One question, sir. Yes, any protocol for pancreatic stent or any cardinal criteria?
Sir, actually we do not have a medical gastroenterology department who can perform endoscopic ERCP and place a stent. But we do have a surgical gastroenterologist here, and we do have all the equipments required, like the state-of-the-art Olympus endoscopy systems. Shortly we will recruit, from July 1st we have a medical gastroenterologist who is going to join our institution, and thereafter I think we will have a dedicated ERCP team. Currently we have upper GI endoscopy and full length colonoscopy systems we have, and we do about 5 to 8 upper GI endoscopies in the mornings and about 2 to 3 sigmoidoscopy or colonoscopy per day. And our department, we also have a very high-end Striker 4K advanced laparoscopy system. So we are doing advanced laparoscopic surgeries as well.
Thank you.
You want me to answer that? Knee surgeries, we are doing the total knee replacements and hip replacements also. We are doing regularly, we are doing it. No, actually from our side it will be free. The patients will not be charged anything. That the insurance of that person will be dealing with that.
ਸਤਿ ਸ਼੍ਰੀ ਅਕਾਲ ਸਰ।
ਸਤਿ ਸ਼੍ਰੀ ਅਕਾਲ।
ਬੜੀ ਖੁਸ਼ੀ ਹੋਈ ਜੀ ਪੰਜਾਬੀ ਜਦੋਂ ਮੈਂ ਸੁਣਿਆ। ਸੋ ਅਸੀਂ ਪੰਜਾਬ ਦੇ ਵਿੱਚ ਪਟਿਆਲਾ ਦੇ ਵਿੱਚ ਜਿਹੜਾ ਸਾਇੰਸ ਵਸਿਆ ਵੈਲਨੈਸ ਸੈਂਟਰ ਆ ਉਹ ਪੰਜਾਬ ਦਾ ਪਹਿਲਾ ਜਿਹੜਾ ਹੈਗਾ ਉਹ ਓਪਨ ਹੋ ਚੁੱਕਿਆ ਜੀ, 3 ਮਹੀਨੇ ਤੋਂ ਰਨ ਕਰ ਰਹੇ ਹਾਂ। ਅਤੇ ਡਾਕਟਰ ਸਾਹਿਬ ਮੈਂ ਜਾਣਨਾ ਚਾਹੁੰਦਾ ਸੀ, ਜਿੱਦਾਂ ਕੋਈ ਮੇਜਰ ਪ੍ਰੋਬਲਮ ਕਿਸੇ ਪੇਸ਼ੈਂਟ ਨੂੰ ਆਉਂਦੀ ਹੈ ਹਾਰਟ ਦੀ, ਨੀਜ਼ ਦੀ, ਤਾਂ ਕੀ ਪੇਸ਼ੈਂਟ ਨੂੰ ਉੱਥੋਂ ਆਪਾਂ ਇੱਥੇ ਮੇਨ ਆਪਣੇ ਜਿਹੜੇ ਮੈਡੀਕਲ ਕਾਲਜ ਆ ਰੈਫਰ ਕਰ ਸਕਦੇ ਹਾਂ ਅਤੇ ਕਿਵੇਂ ਕਰ ਸਕਦੇ ਹਾਂ?
So I'll just translate what he's asking, and he's asking about the patient. They are from they are from Patiala, and they are asking that suppose if the patient is having some acute problem, how we can refer the patients here, and what's the so पहले मैं थोड़े पंजाबी जी गल करके तो आंसर करांगा मैं। इस तरह है कि तो मैं जिन्हें भी सारे डॉक्टर्स ने कार्डियोलॉजिस्ट दे आर अवेलेबल राउंड द क्लॉक। यू कैन कॉन्टैक्ट देम एंड यू कैन टेक द फर्स्ट एड एडवाइस उस वेले तुसी लै सकते हो, तो वो थानू दस देंगे। जदों पेशेंट स्टेबलाइज हो जाएगा फिर थानू असी गाइड करांगे किस तरह तुसी पेशेंट सानू ट्रांसफर कर सकते हो, या कोई होर भी अगर नेड़े तेड़े भी साडा कोई उत्थे सेंटर है उस ते किस तरह, क्योंकि साडा कोई सेंटर नहीं इत्थे, साडा सेंटर पलवल भी है, रायपुर भी है, नवी मुंबई भी है, तो असी थानू गाइड करांगे जदों पेशेंट स्टेबलाइज हो जाएगा। I'll just translate in English, and what I have told him that our doctors are available round the clock and they can be contacted on telephone. And first we'll try to stabilize the patient, and when the patient is stabilized, our doctors will guide you how to refer the patients either to us or to any other nearby center which we are having in India as well as other parts of the world also.
I had 3 comments. One was clearly the referral system, how can you best referral process will be shared with all the teams by the Sai Swasthya Central team. Second, the demo that you saw on the telemedicine, clearly that's going to be another very easy platform for you. जैसे आपने पूछा अभी कि पहला कंसल्टेशन कैसे करें, डॉक्टर को कैसे करें, जैसे ये telemedicine launch हो जाएगा, that will be a good प्लेटफॉर्म आपको फर्स्ट कंसल्टेशन यहाँ के डॉक्टर्स के साथ कराने के लिए, उसके बाद वो रेफरल लिंक होगा। तीसरा, मैं रिप्रेजेंट करती हूँ श्री सत्यसाई संजीवनी हॉस्पिटल्स को, क्योंकि सर ने रायपुर, पलवल, बॉम्बे के बारे में बताया। आई थॉट मैं ये अपॉर्चुनिटी लूँगी हमारे हॉस्पिटल के बारे में बताने के लिए। श्री सत्यसाई संजीवनी हॉस्पिटल डेडिकेटेड पीडियाट्रिक कार्डियक हॉस्पिटल्स हैं। 4 पीडियाट्रिक कार्डियक मतलब जो दिल में छेद होता है, कंजेनाइटल हार्ट डिफेक्ट। 4 पीडियाट्रिक कार्डियक हॉस्पिटल्स हैं, एक रायपुर छत्तीसगढ़, एक पलवल हरियाणा, एक नवी मुंबई एंड कोंडपाका तेलंगाना। तो जो साउथ के अगर कोई भी आपको बच्चा ऐसा आपको देखने मिले, तो मैं आपको अगेन जब टीम आपको रेफरल सिस्टम देंगे, संजीवनी का भी पॉइंट ऑफ कांटेक्ट हम देंगे वहाँ पे, तो अगर साउथ से हैं तो आप कोंडपाका भेज सकते हैं, वहाँ ओपीडी है, सर्जरी सब हो रहा है। नॉर्थ के पेशेंट्स को आप, बच्चों को आप पलवल भेज सकते हैं। ऑल दीज, ये सारे हॉस्पिटल 100 बेडेड सेंटर्स हैं एंड द एंटायर रेंज ऑफ पीडियाट्रिक कार्डियक कैथ इंटरवेंशंस एंड सर्जरीज आर कंडक्टेड हियर। हम लोग महीने में क्लोज टू 350 सर्जरी, 400 सर्जरी कर रहे हैं हर महीना। तो वी विल ये सर्जरी इजीली हो पाएगा। वेस्ट के कोई भी पेशेंट्स है तो मुंबई जा सकते हैं, और अगर कोई कन्फ्यूजन है तो हम एक कॉमन कॉन्टैक्ट नंबर देंगे और हम आपको बताएंगे कहाँ रेफ़र करना है। बहुत बार क्या होता है, हमने देखा है कि एक बेसिक इको टेस्ट हो गया है और कंसल्टेशन से ईजिली हम आप बता सकते हैं कि कहाँ जाना है। तो इसके अलावा 5 मदर एंड चाइल्ड हॉस्पिटल्स हैं रायपुर में, पलवल हरियाणा में। अगर उत्तराखंड से कोई है तो उत्तराखंड राय वाला जगह है, और राय ऋषिकेश और हरिद्वार के बीच में, एक जमशेदपुर में और एक महाराष्ट्र में यवतमाल। तो ये 9 और हॉस्पिटल हैं जहाँ पे आप किसी को रेफ़र भी कर सकते हैं।
Also, very important to note that the Department of Cardiothoracic Surgery, which is headed by Dr. Anand Agarwal sir, is a senior consultant. So his complete training and work was from UK. So he's fully foreign trained, foreign returned, and very specialized surgeon doing all complicated cardiac surgeries, including adult and pediatric, like he was telling. So I think it's better if Anand sir only explains about the scope of surgeries that the department is doing.
See, already I spoke, no, that actually the problem is cardiac surgery is becoming very expensive. बहुत महंगा होता है. I was working at Malla Reddy for almost 15 years in Hyderabad, and before that I was in Oxford, UK. So this is Swami's benevolence actually. So small thing, as Sister Soumya said, all pediatric cardiac surgeries were being done by Swami. So I kept pestering him, whether will I be able to do adult surgeries ever. So in his benevolence, he has given us a theatre and ITO, so we are able to do. And I think more than around 400 surgeries we have done in 1.5 years with excellent results. And we do not turn back any patient, to be honest. And we are very much result oriented. And CTVS, cardiology referral, I have been speaking to Brother Subhojit and all. So we'll need to, for cardiac especially, because time is very crucial, we need to have a separate hotline actually. So that we should make. So any adult pediatrics apart from our, so I think as sister said, north, east, west, and even in Muddenahalli, so we are able to. And actually, as a matter of fact, Swami asked us to go to Fiji. We took a 17-member team. Fiji, we have a hospital, they have conducted more than 350 pediatric surgeries. So Swami asked us to go and do adult surgeries. So we took 17-member team from here. Can you imagine, just as I know our time is very lacking, very, very touching moment. There was a mitral patient waiting there, and she said, we were just waiting for someone to come and do the surgeries. Because if they have to go out of Pacific to any other hospital in India or anywhere, it will cost minimum 30 lakhs. And we all went, and it's all Swami's grace, you know. What is happening here is nothing short of miracle. All of you sitting here, so many Sai Spasya Center. So I think together we should work. You are all on primary level, and there are secondary Arogya hospital coming up, and we are at tertiary level. So I think there has to be a sync. So I think that's why this conference has been designed. Thank you.
Thank you. Any other questions? Request you to kindly collate them, and aapke answers we will get back to you. Or you can take it around the lunchtime or later. Thank you, sir. Thank you for your precious time.
Before we just wind up, and I just wanted to say that we don't do anything here. And I think Anand Agarwal sir and Dr. Harsha, will also agree with me. Everything is done by Swami. We are just his instrument. And because the day to day, when we see the surgeries and all done and how they recover, every day we see some miracles. Every day is full of miracles, and lot of examples are there. And last year, one lady was there who was living in our ashram. She was having blood pressure and high blood pressure from Germany. She is from Germany, and approximately her age was 60, 65 years. And she had a stroke and a brain hemorrhage, and she was on vegetative life in one of the neurosurgery departments hospital there in Bangalore. They said that now we want to switch off the heart-lung machine, and somehow the patient was shifted here. And you will not believe the patient has recovered and drastically. Now every day she is going on foot and coming and fighting with everybody, and every day she is going to Pemamritam. So these things are not done by us. But there is some supernatural power which is working, and we are just his instruments, and we are nowhere, and only Swami is doing. And in our operation theatre also, we have written a subscription there that Swami is the surgeon, and really he is the surgeon. We are not doing anything. So many times, every day we see some or other miracle. So this is one thing I wanted to say. Second thing, I just wanted to inform you that apart from doing a lot of free camps, we are doing a lot of workshops and CMAs also of different departments, which is absolutely free of cost. So if you want to come to attend those seminars, those workshops, those CMAs, you are most welcome. And you can spread this news also among the physicians faculty of your region. So these are two things I just wanted to say.
Thank you, sir. Thank you for your precious time, and we will work with you to establish the referral linkage. Thank you so much. The last session of the day, we have Dr. Devji Patil, who is a senior public health specialist working with several state governments to develop models at reducing malnutrition by strengthening public health nutrition through skill training in lactation, complementary feeding, and adult nutrition. His focus has been non-communicable diseases, and additionally, Dr. Patil serves as a public health consultant with IIT Bombay and is now very active with the Sri Madhusudan Institute of Medical Sciences and Research. He shall be briefly touching upon a very important topic, understanding protein and carbs.
So namaste to everybody. Are you all hungry? Not hungry? If you're hungry is good, or if you're not hungry is good. So thank you. I mean, it's a wonderful session to know Whipples and other procedures being done with such a, it's wonderful. So my name is Devji. What language you are commonly comfortable? Is it English or Hindi? English you are comfortable? So since a lot of my job includes public speaking and training, I'll speak in English. So I'm here today. The next 15 minutes I'll kind of take you through. I don't have any presentation. I have one slide. So you don't worry about something coming to you. But we have developed a very, very new instrument, a very potential instrument which can radically change the way how we approach not illness, but wellness. Can you imagine what that instrument could be? No, not mobile. Mobile is kept here. And it can be carried in a pocket. In fact, I'm actually holding it in my hand. No, it's an instrument. It's not coming from my body. Yes. Thank you. And this is this beautiful instrument. So why do I bring this? So it's a fantastic, I've rediscovered it actually. So part of my journey, so I'll divide this into two specific groups of my thoughts. The first is that, can I walk around? So I've shared with you a very, very beautiful and wonderful instrument. It's very helpful in primary healthcare settings, especially where you don't have instruments and you are not understanding what is happening to the patient and you have very complicated software. How does a measuring tape help us? For that, I take you to my journey. In 2019, I've been a diabetic for more than a decade or so. In fact, I just conducted a session there in Sarla Memorial for the Tyagajivis and also some people who have done the longevity study. It's very interesting. So I have a family of diabetics. So at 40, if you are not on insulin, you are not arrived in your life. Huh? So they will say, what, you are still taking tablets? I'm taking insulin, they will tell. Similar for hypertension. So it was around 10 years, and then suddenly I realized that, are you hearing, no? Okay. Don't worry about it. It's a distraction. You look at me. Don't look at the board. That's why I took the mic. When I was standing there, many of you were actually looking at the screen. So what happened was that I have this illness and I'm on drugs, and I did an investigation and I took it to a very senior endocrinology friend of mine and I showed him the investigation. He said that you have to take 1, 2, 3, 4, 5. So already you are on oral drugs, you have to take insulin, your cholesterol is also very high, so you better go on statins. By the time I had understood that statins and long term, I am not a physician, so I come with a lot of general kind of physician, family physician kind of talk. Okay? I have experience in specialty and super specialty, but I have left it long ago. Primarily, I'm a public health, as a fantastic introduction you gave. Primarily, I'm a public health professional working with ASHAs, Anganwadi workers, so community health officers. Mainly, they are my clients. And here also, we have conducted plenty of workshops for volunteers and things like that. So after a long time, I met the Tyagajivis today. If you are in this campus, you must meet Tyagajivis who are a complete different breed on their own. It's a fantastic set of people. And it's my honor to be of help to them. So the doctor said that you have to be on statins, and I had a problem with statins. So then I said, okay, why are you giving it? Can you explain me what statins do? So the argument came after one another, and then he said, so I asked him twice. He said, third time he said me, look, you have come to me as a doctor or as a patient? I said, sir, I have come to you as patient. So they said, you behave like a patient. No. Why are you asking me so many questions? Doctors have forgotten patients asking them questions, because it's increasingly becoming lack of human touch and increasingly become technology oriented. Technology also has a tremendous potential to alienate people, especially people who are not comfortable in technology and things like that. So I said, okay, so you must be reading a lot, he said. Yeah, I said COVID has happened. They are telling that obesity, hypertension and diabetes, all three people are highly susceptible for COVID. All my family is obese. I was 100 kg at that time. When I went to this person, I was 100 kg. So I came back and I looked at what I don't know. Why did I ask this question to that doctor? I'm also a doctor. He has also gone to the same medical college. He has done read the same book. I have also read the same book. So two questions came to my mind. One is, why did you ask that question to him? The answer came to my mind that you have stopped reading. You have stopped reading. And in this process, what happened was that I read. I opened the books and read a lot about what happens to the metabolism, what is happening inside my body. So I understood that, so that's when I've been working in the sector for nutrition, in public health nutrition for more than a decade by that time. So for the first time, I refused workshops saying that no, I don't have a moral authority to talk about maternal nutrition, infant nutrition or adult nutrition, because your own nutrition is really not on the same platform. So one of the things what I did was looked at the Indian food composition tables and actually understood that I'm consuming a lot of some things and not consuming a lot of something else. What were those? So very interestingly, the entire nutrition sector, if it can be summed up, it can be summed up in three macronutrients: carbohydrates, fats and proteins. So when I looked at my calculations, I calculated actually food. So there is one more instrument which I have kept it there, which is very important for me, is the measuring cup. So once I measured what I was eating, all happening in my kitchen, no aid. And I also did a metabolic profile, because then I started getting to know what all information I require. Why do I require it? What are the misconceptions I'm having? Because there are several misconceptions which I had kind of ingrained through my training and not really bothered to check them at all. Because ek baar MBBS, after you finish MBBS, hardly you go back and touch the physiology or biochemistry books. This is somebody else's domain, they think. They can do whatever they want to do. But it's good if senior, once you get into the whole process and then get back to the basic science, and it will help you. I found out that I was consuming around 700 grams of carbohydrate per day, and in the weekends it is used to go up to 1000 grams on an easy basis. I have no addictions, I sleep well, morning 1 hour of yoga is done, Surya Namaskara is done, everything is done, I'm good at work, I'm happy at work, happily married, no problems. Cholesterol is very high. Everybody has this problem, no? So if somebody comes to you, what do you ask them? What do you tell them? So if a diabetic comes to you, do you ask them to do cholesterol and discuss about cholesterol to him? No. A diabetic comes to you, he undergoes the same experience what I have undergone. They will ask him, what is your blood sugar? Morning, after 2 hours, then job is done, prescription is written, you are packed off to a different department. That is called as the nutritionist. Done. So the clinician is absolutely free of any other thing. I also realized during this process that doctors do not ask the patient, what did you eat? What food do you like? What food appeals to your body? So there are a whole lot of questions based on food they did not ask. So during this process, what I felt was that, okay, so the next next 9 months was a serial reduction in carbohydrates and serial increases in my protein. 3 months down the line, so 9 months down the line, as though I am a newborn, newly delivered baby, I went back to the same friend with another investigation. I said, I removed the name and asked him, what did this person has to do? He asked me, how old is this person? He must be our same age, 50, 55, like that. So then I said, this fellow is hale and healthy. Why are you thinking even of putting him on any drugs? This fellow will improve by, he has got nothing. He just has to make some small corrections, walk around, and then I told him that these both investigations are my investigations. So can you believe that a person with HbA1c of 10 can come down to HbA1c of 5.4? You should believe. And he also will lose 25 kgs of his weight. And then we come here and talk in front of you about what is happening in the sector. So if you can put that, you cannot put the slide, no? That's not working, no? I have given you one slide. I'll just, so just to be on a safer side, I'm having very less time here. This is a 1 hour workshop. 1 hour, actually 2.5 hours workshop, and which can continue over a period of time. I just want you to focus on the top one. Can you expand it? Can you bring it down and expand it? Bring it down and expand this. Okay. Every gram, so don't worry about it. I'll explain to you. Every gram of carbohydrates which go extra in your body are converted into fat. This is basic fundamental physiology. It's undeniable physiology, and it gets stored. The fat gets stored here in your subcutaneous tissue. The fat can get stored in your visceral area as fat. Fat can also get stored in your liver as liver fat. So if you go to a place and then investigate that person, just random, your ultrasound scan, the radiologist will say grade 1 fatty liver. You have never touched 1 drop of alcohol in your body, in your life. What happens if your stored fat is not metabolized, is not removed? This stored fat will lead to what are called as, it will release what are called as adipokines, and these adipokines will actually cause inflammation to heal everywhere in the body, and to heal it, you will get the cholesterol which will come and try to do the healing work. That's when you put the stent and find out that his fellow has a block. So what we call as clinical medicine is appearing after a very, very long journey. So all the labs, all the angiograms, all the investigations are picking where? Picking at illness levels. Now, if you have illness, you can be illness of a small quantity, but you can also be severely ill also. But similarly, from the illness domain, you can actually be in a wellness domain, and in the wellness domain, you can be thoda well, jada well, or supremely well. Supremely well. Here, in this slide, what I have shown is, I've completed 15 minutes, huh? I'll take another 5 minutes. So what happens is, the more fat gets deposited and the more your insulin will not work. And that is called as, can you put that please? And that's called as insulin resistance. It's not working. It's there. It's not working. If you test that person for insulin, fasting insulin will be very high. So this is from a curated literature review. I'll be able to take this question. Just look at it. Skin diseases, acne, dry skin, skin tags, eczema, lung diseases, sleep apnea, asthma, cancer, colon, breast, prostate, liver, pre-diabetes, diabetes, high BP, kidney, heart stroke, lipid abnormalities, fatty liver, joint diseases, rheumatoid arthritis, gout, PCOD, low testosterone, erectile dysfunction, GI problems, reflux, irritable bowel syndrome, gallstones, pancreatitis, neurological conditions like migraine, seizures, dementia, Parkinsonism, multiple sclerosis, Alzheimer's, and psychiatric disorders like bipolar disorders. In the single slide, it summates the problem in which our entire medical system is grappling with. especially when the preventive system is not working. Wellness system is not working. This is what happens. Because each of these subdivisions are different branches of medicine now. लिवर के लिए हेपेटोलॉजिस्ट होगा, डायबिटीज के लिए इंटरनल मेडिसिन होगा, जॉइंट के लिए ऑर्थोपेडिसिन होगा, और रूमेटॉइड आर्थराइटिस है तो रूमेटोलॉजिस्ट होगा, स्किन है तो डर्मेटोलॉजिस्ट होगा, सीजर्स है तो न्यूरोलॉजिस्ट होगा, स्ट्रोक है तो न्यूरोलॉजिस्ट होगा, वगैरह 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 वगैरह. So what has happened is, in the process of not understanding what basic nutrition means, we have landed up in a diverse phenomena of departments. What will happen with these departments? They will treat and treat more and more patients. Footfall will be enormous. Burden on each of the treating clinician will be very high. And that is a low, it's a kind of burden which he would not want to do. Why should Professor Bali not do, the skull-based surgeries forever? Because the load is 1,400 cases per day, if I am not mistaken. So what happens is, if preventive approaches are not applied well, then your curative services will become extremely taxed. Extremely taxed. So there are 5-point program and a 12-week program, 5 points and 12-week program, what we are planning in through the preventive and social medicine department here. I'm not sure any one of them, only Mritsna is here, but Nandish and Fanindra, Nandish is here. So what we are trying to do is to evolve this into a preventive approach based on nutrition and understanding of physiology. It will have a significant change. Already the Pairotale Dharti is moving in the West. They are understanding that, the obesity epidemic, the diabetic epidemic, what America is facing, it's happened because of refined carbohydrates. Refined carbohydrates, seed oils, which are unhealthy oils, which are marketed as vegetable oils, and lack of use of saturated fats, and also a very, very stressful life. So how do you kind of come back to the solid preventive approach? It's a 5-point program. 1 is reduce the consumption, count your proteins and carbs, number 1. Number 2, once you count your proteins and carbs, take corrective measures in your diet. 2, exercise. Don't just walk around, lift some weights, go to the market. If you buy vegetables, carry them in your hand. तो 5-5 किलो का अगर तुम कुछ लेके आओगे मार्केट से 1 किलोमीटर चलोगे तो कोई दिक्कत नहीं होगा. It will be very good. You need not go to a gym for that. 3, understand fasting. Understand fasting in a very, very clear sense. Fasting does not mean eating sabudana vada. Or say that I will have 2 idlis, instead of 10 in the whole day. A lot of idlis are consumed by South Indians. If there is a idli in the house, idli in the morning, idli in the afternoon, idli in the evening, and idli in the night. Only thing is that idli can become a dosa. It can change its form. So remember, we have become, it was very interesting, one of the pharmacology department professor, I don't know whether she is there or not there here. So I asked her, did Tamilians consume idli like this all the time? She said, yes. So I don't know, why don't you ask your nani? She might tell you differently. Each of India's areas, भारत में हर एक प्रदेश में पिछले 50 साल में जो खाने का प्रथा बदले हैं, उससे बहुत बड़ा नुकसान इंडिया झेल रहा है. What I told was, because of the change in food habits in the last 30-40 years, you have a very, very difficult health paradigm in India. Okay? So if you fast, it's not about fasting foods. 12 hours after you consume your last meal, it's considered as fed state. After 12 hours. So yesterday night I have taken morning 7 a.m. tak fed state hai. From morning 7 a.m. the fasting starts, and it can go up to 24 or 36 or 72 hours. But a wonderful thing happens after the 17th hour of fasting. The body identifies Three kinds of cells. One, dead cells that causes the wrinkles. Dying cells, aged cells, circulating, or dead cells who are circulating, or aged cells which are aged. And then malfunctioning cells. Malfunctioning cells are those cells which will, आगे जाके वो क्या बनेंगे? They will become cancerous cells. The body will identify these three specific kind of cells, and in the process of optimizing the function of the body, will identify them, digest them, break them down, take the useful components, and remove the rest of them. So, if you are able to do a 36 hours fast or a 72 hours fast, be very sure that at the end of 72 hours, you are not the same person, literally. Because every old thing in your body is removed. It's done and dusted away. It's a fantastic housekeeping activity. This phenomena, which is known to the civilization called as Bharat, in our subcontinent, for all the religions which are existing in the subcontinent, is known as autophagy now, and that has got a Nobel Prize in 2009. Okay? And Ekadashi we have been doing from 12,000 to 15,000 years. Something like that. So, what I do is club these things and then give a program where the person has a clear shot at remission, clear shot at removing his drugs. The doctors who are serving at premier institutions, especially highly technically endowed ones, should not be burdened with, they should be burdened with cases which will test their abilities. Test their abilities. If they are burdened with lot of mundane cases, then they will function at less optimal state. So this is my first interaction with the Sai Swasthya Wellness Group. I thank you for giving me this opportunity to briefly introduce you about what we do, and we have a good amount of case experience which are accumulating over a period of time. So we talk to everybody who is concerned, and I also talk much from my my own individual experience also. Here I will end and look at this. These are the roots of insulin resistance: chronic stress, ultra-processed food, sugar, lack of sleep, refined carbohydrates, sedentary lifestyle, not just any seed oil, but refined oil. Refination of the oil process actually harms the oil a lot. For example, if you have a very beautiful actor coming and selling you, take this fortune oil, it does not have smell, it does not have chipchipahat, it does not have color, then he's not selling you oil. He's selling you something else. Because each of our sensory, food is not just a, food is an emotion, they tell, no. For example, for him, if you are looking at what you call sarson da saag or something like that, it's very closely connected with the life what we lead. Food is also very olfactory in nature. Food is gustatory in nature. And food has a potential to make or break even relationships. So one of the things which is going to come up. I'm talking to you about, I'm actually a link between a very distant past and actually what's happening in the society now. Increasingly, India has become aware of the problems of carbohydrate, especially wheat. And the wheat has caused havoc in Punjab and other places. We understand that. We also understand that ancient millets save us. So there is a huge kind of awareness that is going around on millets and millet-related products. But also, if you look at Amul protein products, none of them are on shelf. Amul has one of the largest repertory of protein products: protein lassi, protein dahi, high protein milk, whey powder. Nothing is available on shelf. That means rapidly flying. So when we look at investigations, we need to, we have technology, we can diagnose a thing better, faster, earlier, and detect and treat. That's one aspect. But there's a whole lot of aspects which is covered in the term wellness, and that means that your patient should not go to a hospital. So last but not least, I will do a small exercise with you. Please open your book and write in that book, my age is. You write your age. My age is. Whatever it is, you write your age. It can be 20, 30, 40, 50, 60, whatever it is. Whatever number you have written, on the top of it, you write 100. Now you subtract 100 में से तुम्हारा age को subtract कीजिए. You subtract your age from 100. So you will get a number. Don't, now if I ask you, what is your plan for that number? What is your plan for that number? So that will give you the essence of what is long life. It is no longer necessary, it's no longer possible for you to just wish your child 100 years of life. Are you capable of understanding what is 100 years of life? Are you able to, are you just wishing the child just like that? अरे हमें ही यकीन नहीं है कि हम 100 साल जिएंगे. अरे डॉक्टर्स को आप पूछोगे ना. If you ask a doctor, he'll say that 65 years I can live. After that, it's all bonus. That's what I will tell. Our ancient have structured this 100 years and made that wish. So please remember that when something is given in the scriptures or something like that, if they say that you need to live to 100 autumns, 100 seasons you have to see, 100 summers or 100 winters, 100 springs you have to see. Like that you live. If you tell your child, if you don't know, how will you make that child, or if you don't believe in that statement, your child will not live 100 years. But it is possible if we make lifestyle adjustments in the way how I have told you. It will definitely give a very clear picture about what does it mean to live long. So very mishmashed, very crisply I have tried to communicate something to you. Lot of inconsistencies. I'll be very happy if anybody of you will approach me and ask me to talk about it to you or your friends, your family. We are more than willing to do that. Thank you very much. Yes, you can take any food during fasting which will not cross insulin. That is the beauty. Because once the insulin level comes down, circulating insulin comes down, then the metabolism shifts from fat storage to fat metabolism. As long as insulin is high and circulating in the body, the metabolism is towards storing fat. And dietary fat, whatever fat you take, no, it will not become cholesterol. Remember this. Dietary carbohydrate has got a straight pathway. It will form your fat. That's the way how the metabolism is there inside. Yeah. Yeah. You have. So you don't worry about it. We can circulate to the team as to what each food contains, how much carbohydrates, how much proteins we have done. In fact, we are one of the only institutions, I think, which is actually looking at the entire gamut of activities. That means infant, young child, breastfeeding assessments, young child, and also adult nutrition. So we can give you the formulas of what to do and how to do it. Yes. So the tape is coming because of very interesting thing. Please, you can write it down. Adult male, waist circumference, if it is more than 34 inches. Write it down. Adult male, irrespective of how much time you spend in exercise or whatever it is, na? Adult male, if the waist circumference is more than 34 inches, it means your metabolism is risky, which means you have potential to have all the things whatever I am saying. Okay? that indicates fat storage, that indicates a different metabolism. What about in female? Adult female, if the waist circumference is more than 30 inches, 30, waist circumference 30. Huh? So if you look at, I just took my mother to Belur and Halebeedu, you know. You know, Belur and Halebeedu is a place where ancient sculptures have created beautiful, what I can say, idols. Where, you know, if somebody says, no, somebody is very beautiful, oh, she thinks like she is Belur Shila Balike. Like that we will tell. Do you know the proportions of that waist? None of the Shila Balikes are obese. None. In fact, in our entire thing, only Ganapati is the one who is obese. And that is also a different kind of, 20% of people are like that. So the waist circumference, if it is more than 30 inches in women and 34 inches in men, it indicates that there is a problem. However, I would excuse people who are above 65, 70 from this rigid kind of understanding. But it's true for rest of them. Thank you.
Thank you, sir. What a lovely takeaway message for all of us. I think before we talk about prevention, promotion for the society, let's apply it on ourselves and take this guidance. This concludes the end of session 1 of day 2. Thank you all for sitting through this. We hope that the sessions today were helpful to you. We know that some of them were only demonstrations, but that's what the objective was, to make you aware. आगे जाके इसके implementation plans और details और आपको बता दिए जाएंगे. Again, thank you for taking time out and coming till here. This evening, we will have a session with Sadhguru at 4:30. All of you are required to please be seated by 4. This will be a fairly personal session. We will also have an opportunity to have some photographs with Sadhguru, team-wise. If possible, actually, let's make it 3:45, because we will do a quick demo of how to arrange yourselves for the photographs. So 3:45, we will meet in Premamritam, and thank you again. Sorry, just a quick announcement. We are having a shortage of buses because it is Sunday. So all the doctors and senior members, we have one bus available right at the entrance of this building. For the rest, if you can just walk a little bit up to Premamritam, there are buggies. And for all those who want to reduce waist sizes, you can walk. Thank you.